So good morning, it is just turned 10 o'clock. It is Monday, the 25th of October, and good morning to both those in the chamber and those online. So good morning, welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those people who want to watch the session back, the recording can be found on the County Council's website. The meeting is being beamed live for people involved, but I would just mention there is a 20-second delay in cut-off, so maybe restrict any private conversations till 20 seconds after we have finished recording. All voting committee members are in the chamber in person, and there is a variety of colleagues from within the social care and health sector who are principally online. We will get them to introduce themselves in due course when the items come up. So just in preface for today's meeting, can I ask that our presenters restrict their opening comments to no more than 10 minutes, and in some cases, because of the packed agenda, I would like that to be lower if possible. Particularly if committee have already seen things several times before, let's use our time wisely. And can we also focus on those tangible outcomes for the residents of Staffordshire? Before we start this morning's committee agenda, I would just like to thank County Councillor Anne Edgeler for a superb and informative meeting on mental health, and also thank Deb Breeden for all her linking and leading on pulling together a very useful session last Thursday on mental health. I think we should discuss the outcomes from that as part of our agenda item, even. Number 10, which is about the forward planning. So if members can think about that as we go through the agenda, I'd be grateful. And for those people who didn't see or weren't able to attend, the session was recorded, and I would encourage members to go back and have a look at that huge packed set of information, which very difficult to take all in first time because of the sheer volume of things going on. So I would encourage members to look at it again, and equally, please do feel free to circulate those resources to district and borough colleagues within your committees. David. Yes, you will. Those will be circulated separately, but also put onto the shared space within our web area. Resource, that's the word. The second thing I'd just like to say in terms of starting this morning's meeting is to wish County Councillor Phil Hewitt a speedy recovery, and may I suggest that he takes his own health and safety, especially at home, as a higher priority, and maybe he can join us in person next time. Thank you, Councillor Buttery. That's very kind of you. So let's start this morning's agenda with item 1, apologies.
Yes, Chair, we've got apologies from Councillor Charlotte Atkins, Philip Hewitt, Joyce Bolton, Rosie Claymore, Keith Flunder and Thomas Jay.
Thank you, that's very helpful. Can I just confirm that we are quorate?
Yes, Chair, we are quorate.
That's great. So item 2, declarations of interest. Anne Edgeler.
Thank you, Chairman, and good morning, everyone. Yes, I'd like to declare I'm a partner governor on the MPFT from the County Council.
Thank you, duly noted. Richard Cox. Thank you, really helpful, and you declared that before as well, and I recollect that. Thank you. So, item number 3, the minutes of the last meeting, which was held on the 20th of September. I'd just like to make a couple of comments, which I'm sure members will have picked up on. On page 1, Lynn Miller doesn't have any, and I think it's important we get that corrected. On page 3, second paragraph under item 29, line 3, I think the word is prioritise rather than priorities, without me being pedantic and putting my school master, which I wasn't, hat on. On page 6, second paragraph, line 2, I think the word is increased rather than increase. And on the same page, under the paragraph which starts, the chairman encouraged members to attend, I think it was the local outbreak control board rather than the locate outbreak control board. I think they're all, it's easy to understand the meaning of what's there, but always good just to tidy those minutes up. Has anyone else picked up anything in terms of accuracy of the minutes? I'm not getting anything, so on that basis, can I have a proposer and a seconder for accepting the minutes as to an accurate record? We've got Martin Buttery and Richard Cox, thank you. Are we all in agreement? There you go, I think we're all in agreement. And matters arising not on today's agenda, there is none. So on that basis, let's move on to item 4, please. This is the quality assurance of independent hospitals providing care for patients with mental health and or learning disorders. Just as a preface to this, the purpose of the session this morning is to give assurance to committee that we are offering our residents the best possible care, preferably in county where the facilities exist, and if not, out of county. But members will remember the Elder Tree Lodge in Loggerheads near Market Drayton, which has now closed, but which had a CQC rating of requires improvement back in March 2020, but had space for 41 inpatients. And I think this is a way of committee getting assurance that the quality, safety and standards are appropriate for Staffordshire's residents. And that is something that we agreed as part of the original scoping meeting back in June. So I think Heather is leading us on this morning. Heather, do you want to introduce the team you've got with us and then just take us through where you want to lead us to, please?
Good morning. Yes, thank you. So for anybody who doesn't know me, I'm Heather Johnston. I'm Executive Director of Nursing and Quality for the 6 CCGs in Staffordshire and Stoke-on-Trent. And this morning I'm supported by Ben Boyd, who will introduce himself in a moment, I'm sure, and by Mary Barlow, who works in my team and who's played a very central role in the work that we've been doing over the last few months to manage these particular facilities. So Mary might turn a camera on in a second so you can all see who Mary is. So without further ado, I'll get started, and I don't intend to necessarily go through slide by slide on the presentation. There is a lot of information in there, and I do apologise that we've used some NHS speak, some NHS abbreviations in there, which we've not explained, so I will pick those up as we go through. But just to give a bit of background context, and I was going to introduce the recent closure of Elder Tree Lodge, but you've rightly beat me to that. But we wanted to come along and give you some assurance, and particularly some positive assurance around the action that we're taking in Staffordshire and Stoke-on-Trent to make sure that, as you rightly say again, our patients are safe, where possible that they are looked after, cared for in facilities in Staffordshire and Stoke-on-Trent, but where they are needing to move out, that we stay very, very close to their care and have a good grip on what's happening with them, particularly in terms of the standard of care being provided by the facilities that they're placed in. So if I may, just in terms of Elder Tree Lodge, you're right, there were 41 beds in Elder Tree Lodge, and following the CQC review in March this year, we were alerted to the fact there were some very serious concerns. And as you know, and as we all know from the media, what actually ultimately happened is that that unit closed, and all patients that were in the unit at the time needed to be safely relocated to alternative facilities. And the team that are on the call with me today played a really active role in that transfer of those individuals concerned. I am the named person in terms of the NHS host commissioner guidance for these individuals. So for the 5 mental health and learning disability units that we offer in Staffordshire, I'm the named lead. But we link very, very closely with North Staffs Combined, who took over the responsibility for commissioning care for people with learning disabilities under the former Transforming Care programme from April this year, hence Ben's involvement. So I'm going to start by talking about the work that we have in place to oversee quality, and then Ben's going to pick up more specifically around the wider commissioning. So the host commissioner guidance came out in April, came into being in April, actually came out in January. And what it meant is that we needed to really revisit the systems and processes we've got in place to oversee quality. Now, that's not to suggest that we weren't overseeing quality before. It just meant that we had to make sure we were able to demonstrate that we were meeting criteria, a set of criteria as outlined in the document. And the first slide in the pack just details exactly what arrangements are in place to make sure that we can do exactly that. And you'll see from there that we are meeting on a regular basis, and we're meeting on a regular basis with both providers, but also with system partners to make sure that we were fully aware of any emerging concerns. And that's normal practice for us in the NHS across all of our providers, not just these particular facilities. Now, we hadn't specifically picked up any major concerns in relation to Elder Tree Lodge prior to the closure, but of course, when the CQC go in with a whole army of people, significantly more people than we'll ever be able to provide from a relatively small NHS organisation, and with a greater deal of expertise, they will always pick up things that we'd not necessarily identified. So once they'd alerted us to those concerns, we very, very quickly got involved with the management of and the closure of the unit. This was outside. This is our normal monthly process of review of our providers continued. So we continue to do that with all of our independent hospitals, and then we took on an extra stream of work, if you like, around the specific management of that closure. I think before I move off Elder Tree Lodge, it's probably worth me reassuring everybody that what we did do is, ahead of the required deadline of mid-June, we did get every single individual in there to an alternative placement. And I'm delighted to be able to report that the majority of the individuals who were moved have either settled in their new placement or some have been discharged. And we've had no reports of any adverse outcomes, a direct result of the needing to close Elder Tree Lodge. So what we've done is carry on to enhance our existing systems and processes to oversee quality for this population. And the Host Commissioner guidance that I referred to previously required us to not only monitor our own placed patients, so where we have patients in our own area, we have a requirement, a responsibility to monitor them on a 6 to 8 weekly basis and make sure that they are safe and well and being properly cared for, but also that we link in with placing commissioners from out of area who send their patients into Staffordshire. So quite a large number of the Elder Tree Lodge patients were from areas as far afield as Essex, Wales and beyond. And the Host Commissioner guidance has required us to establish a system where we can monitor, link in with those placing commissioners and make sure that they monitor any areas of emerging concern. So we have really, really strengthened our working relationship with those placing commissioners as part of the development of this whole Host Commissioner guidance, implementation of the Host Commissioner guidance. So we already had really, really good contacts for each of the hospitals in Staffordshire. We'd already got good relationships with the CQC. And as a system, so working with our partners in North South Combined Healthcare and in Midlands Partnership, but also with the local authorities, we've got really good working relationships through those routes. And of course, safeguarding is integral to all of this work that we do, and I sit on both safeguarding adults and children's boards, so we've got good connections with safeguarding through our designated nurses and linking in with the other teams. We've set up a system where we now have a generic inbox where if people are placing from out of area in our area, they can alert us if they pick up a concern as part of routine monitoring. Which is really, really helpful because it enables us to act in the event that any concerns were identified. And we undertook a very comprehensive gap analysis in terms of the requirements of Host Commissioner guidance to make sure that we weren't complacent in any area where systems and processes were already established, that we could actually work to strengthen them and get our absolute best possibility to make the improvements that we need to. We have a system-wide memorandum of understanding with our acute mental health providers, so the two providers that I talked about previously, And where there are problems, we call on them for their expertise as employers of people with mental health and learning disability specialist skills to come and support us to monitor care. Now, there have undoubtedly been some issues along the way. So we know that placing commissioners, certainly historically, didn't routinely place us when they placed in our area. And of course, there's been a significant amount of work come with the Host Commissioner guidance, but no additional resource. So we've had to add that onto people's day jobs, and that's fine. We've got on and done that. But actually, in hindsight, if we'd had some dedicated resource to do that, then we may have been in a slightly better position. Significant amount of work, as you would imagine, comes out of a provider failure, even one with only 41 beds, of which only 24 were full at the time of the issues being identified. But actually what we've done, as you would expect, is prioritise patient safety over everything else. I think just before I hand over to Ben, a couple of other points to make really. We've on the back of having managed Elder Tree Lodge immediately after the Host Commissioner guidance came out, we've developed a number of additional processes. So we have a provider failure standard operating procedure that now is part of our toolkit, if you like, for managing these facilities. And we've also undertaken a face-to-face site-based visit on each of these locations to make sure that none of the concerns that were picked up through the Elder Tree Lodge experience are going unnoticed in any of our other providers. And there is a proactive programme of visits, again supported by specialists from relevant areas, that's taking place across the system on a regular basis. We're also, I'm very pleased and proud to say that we're sharing some of our template systems and processes at a regional and national level on the back of some of the positive learning that came out of a very difficult experience. I think, the bottom line for me really is that I'm hoping that what we've given you here in terms of presentation gives you some confidence in the systems and processes we've established to make sure that these units are safe and that we can monitor and pick up and will act when issues are identified as part of the visiting programme. I'm just conscious of time, so I'm going to shut over and hand over to Ben very briefly, and then we'll be happy to take any questions.
Thanks, Heather. I'm Ben Boyd. I'm the Associate Director for Specialist Services with North Staff's Combined Healthcare. There's two populations I'd like to draw your attention to. There's the learning disability and autism population who were largely placed at Elder Tree Lodge and other places. And then there's the mental health population. So the learning disability and autism population, there's currently 15 individuals who would be subject to independent hospital placement. Of those, 6 are currently in NHS facilities. And I draw your attention to that because I think that will be a trend going forward. Within combined healthcare, we're about to spend about £3 million upgrading our learning disability inpatient unit. And we see that as a different way of managing folk to get them to community placements rather than send them out of area or to out the NHS. But we do have 2 providers we're currently using where we have concerns. Both are out of area, I'm pleased to say, rather than in area, and we are working closely with both providers. Currently, it's felt that the service users in those facilities would be better off staying there rather than transferring them to a hospital before transferring them again to where they need to be going to, which is the community. So, but all 3 clients have had a safe and well check, and we're satisfied that they are safe and well in their current placement. The larger group is the people with mental health independent hospitals, and we currently have 84. Oh, sorry, my presentation is stuck here. See, we currently have 84 in those placements, and but half are in area and half are out of area. So we have a number of providers in the area who are causing concern and we're working very closely with. The biggest of these is John Munro, but the vast majority of providers we use, 21 of 26, are rated good or better by CQC. And what we are planning to do and have started doing is Each provider will now have a contract with us, with an NHS contract, that does have quality and operational standards stipulated that we will maintain at all time. So that shifts the relationship away from simply looking at individuals. We're now reviewing the organisation, and that was what we learned from Elder Tree Lodge, that individuals might feel very well catered for, but the organisation within which they're being cared for has some serious concerns about it. We're also very conscious on the mental health side that within Staffordshire and Stoke-on-Trent, we're overly dependent on independent hospitals. So we have commissioned a housing sector organisation to help us look at alternative placements that are not independent hospitals in the county, and that's just started. But again, one of the key learning items from Elder Tree Lodge was that our staff need to go and do face-to-face, in-person reviews. We can't rely on virtual or remote reviews. They've got to be there and do it in person. Thank you very much.
Brilliant. Thank you for that summary of the slides and the slide decks that we'd seen. I'm going to open the floor up to questions. I'm not seeing anything just at this moment, which is always good news, because that means that A, the slides were clear, which I think they were, and your presentation was as well, so thank you for that. I did want to just use Chair's licence and ask a question in terms of, you've indicated some of the lessons learned from Elder Tree, and I'm assuming there was a formal process that you've been through in terms of the full lessons learned. Are you able to share any more of the lessons learned from, because it wasn't just Elder Tree who failed, it was another previous provider, can't think where else in Staffordshire, a couple of months before that, wasn't there?
Yes, I think you may be referring to the John Munro Group. So there'd been some media attention in January this year following a few issues with the John Munro Group, which has two facilities, one in Leek. I think they're both in Leek, actually. John Munro and Edith Shaw are the two facilities. I think that it wasn't a failure that resulted in closure in the same way that the Elder Tree Lodge one did. So John Munro Group had a COVID outbreak, and on the back of the COVID outbreak, a number of other concerns were identified. CQC went in and did a routine visit, and we developed a comprehensive quality improvement plan with the John Munro Group, and were able to work with them to the point that the CQC stopped coming to our regular meetings, and we phased out our regular quality improvement meetings and went back to routine monitoring with them. However, I can tell you that the CQC went back in summer this year, and the John Munro Group are still subject to some further improvements. I think, I think that probably is the facility that you were talking to, Chair. And if not, I do apologise. So I think in terms of lessons learned, I think we've still got a long way to go, actually. I think we're still learning. The Host Commissioner guidance was new. We've just gone through a period of transition where the Transforming Care Programme commissioning went over to North Wales Combined, as I said before. And I think really, really importantly, and everybody is more than fully aware of this, of course, for the first time in our careers, most of us have been working at home. And whereas historically we would have gone in and done face-to-face visits routinely, we were actively not doing face-to-face visits unless there were explicit concerns about a provider or an individual based within a provider that would warrant the risk to staff and to patients of bringing in increased footfall into a facility. Now, on the back of the learning from Elder Tree Lodge, that has been one of the probably the most important points. So where there are, even the slightest concerns, we will go in and do a face-to-face visit. Obviously, depending on the COVID situation at that time, we'll do a full risk assessment and provide people with PPE. But actually, I think, doing that programme of proactive visits to all of those facilities on the back of Elder Tree Lodge was a really, really, really positive step forward. I think all the other lessons relate to things that we've alluded to, but not necessarily expanded on. We have got a document that we're working with NHS England on, which will reflect all lessons learned from the Elder Tree Lodge experience. And it may be easier if I say to you that I'll share that with you once we've got at least a nearly final copy, so that you can see exactly what we're documenting in terms of ensuring that we don't find ourselves in this position again. And actually, equally importantly, that if we do, because of course some of these closures will always be beyond anybody's control, certainly beyond our control, then if we do, that there's lessons learned in terms of how we manage the situation and how we deal with the challenge of relocating large numbers of very high risk individuals.
Thank you, Heather. I think that's a really useful response and suggestion. Just a couple of comments. One is obviously, these are independent providers, so I understand the point that you're making there. Two is, I'm sure everyone, both on this call and in the chamber, would also recognise that these are some of our most vulnerable residents within Staffordshire, and actually maintaining quality and standards is really important, particularly as their voice might be unheard within some of this. So I really appreciate that. But I think your suggestion of sharing with us the document that you're working with NHS England on post-Eldertree is a really good suggestion, because it'll allow us just to quietly go through that and make sure that we've got that assurance. Can I bring in Anna Edgeler, please?
Thank you and good morning for your presentation this morning. My question really is, how often, I notice we've got so many people placed out of county, how often are these premises visited by our own people? I'm not talking about the people that's looking after the home that they've put in there, the people that's in there, but how often do we monitor these places and do we visit them individually? All right, I go back a long time, but my son was placed out of county, and I've got to say I came home in tears many a time, but I knew I couldn't take him out of the system, because if I did, it would be reliant on me to be able to look after him, and County Council would have washed their hands of him. So I'm just worried about the people that's placed out of county, that we keep check that they are being looked after okay. Thank you, Chairman.
Thank you. Shall I go first, and then Ben, you may want to add to this. So certainly from a learning disability and autism point of view, as placing commissioners, so if a learning disability autism patient was placed, say, for example, in, I don't know, Lincoln, let's just pick Lincoln because it's the first thing that came into my head. We have a responsibility as the people who commission that package of care to go and check that individual, if it's an adult, on an 8-weekly basis, minimum an 8-weekly basis. However, the host commissioner has a responsibility to ensure that that facility is safe, and if it's not safe, or if any concerns are identified, under this new guidance, they have a responsibility to bring that to our attention. And that's what we did with Eldertree Lodge. So just to illustrate that a little bit further, where the placing commissioners were these Essex people or Wales or wherever, we required them, we didn't ask them, we required them to attend a meeting where we could say to them, we know Eldertree Lodge has issues, this is what's being done. We need you very, very quickly to source an alternative placement or placements, possible placements, for your individual patients, so that they can be safely transferred, because we cannot assure safety at that point. And one of the benefits of the host commissioner guidance is that places that responsibility on each of the host commissioners. So Ben, do you want to add in terms of the wider mental health?
Yeah, I say we are stipulating that regular in-person review, and just to give you some assurance on that, our furthest flung individual who's in London, in a very specialist placement in London, our member staff has been there and visited in person. And I think that's the shift we're moving to, that there'll be a blend, of course, working with host commissioners and providers remotely, but we want to see at least one review of our staff going in person to visit the individual and see what's going on.
Anne, do you want to come back?
Yeah, thank you for that. Can you also tell the committee, do we help the families? If these people are placed, say, down in Essex or somewhere like that, do we help the families with financially actually to go and visit them? Because probably some of them can't afford the train fare, and do we help them in that situation? Thank you.
Yeah, there is a national scheme whereby relatives can claim back any expenses, and if a family had problems up front travelling, we would certainly help them with that as well. and not just claiming stuff back. So that has happened, I can tell you. But we try and avoid those far-flung placements as much as possible, and that's the best solution, I guess.
Is that okay, Anne?
Can I also ask, do we have enough, do you find that we've got enough beds to be able to accommodate the people that need them? Or is that a big problem as well?
If I can, Heather, it's actually, and the challenge is to move away from beds. I think we always will need some beds, and I say we are very clearly commissioning those from the NHS wherever possible, and that's appropriate. But I say what most of these folk need is a home rather than a hospital, and that's the challenge for us. And I say we are looking out with our own specialism now and asking housing providers to come and talk to us about what could we do differently. We know in some parts of the country, even folk at that higher level of care need, who historically would have been in a locked ward, there's now some projects around the country where they're in a community placement that's got higher levels of security and staffing, and we are seriously considering that type of arrangement in the county. And equally, what can the NHS do that we don't have to go to the independent sector and provide? So there's a blend there, isn't there?
I do apologise. I did mean home and not beds, really. Thank you.
Ben, I think that was a really useful answer because it touches on what's the policy of the county council or not the county council, but what's the policy within Staffordshire, and I think that's really useful, which is the focus is on in community rather than in placement. Do you have an idea in mind as to how low that number could become in terms of in placement?
Again, if I may, Heather. It's well, I think it's 0 for the learning disability and autism population, although I suspect we'll always have a small number who are in crisis and who need a higher level of support. And again, there's no reason why NHS facilities can't be used for that. Mental health is a bigger challenge, and I think that's not just in Staffordshire or Stoke-on-Trent. I think that's across the country. But if you think about it, 10 years ago, that number would be 84. It would have been 120. 5 years ago, it would be 90, and now it's at 84. So there's a natural trend anyway. I think what we're trying to do is accelerate that and get down to a really low number, around 20 or 30, and all in area, and only those who absolutely need to be in a hospital bed or in a hospital bed. But that's the challenge for the next decade.
Really useful response, and great to see the ambition in that area, because I think you're absolutely right that most people would prefer, where possible, to be close to family and in community. Just as a comment in passing on that, I don't see any further questions. I do now, blimey. The comment I was going to make is, wearing a different hat, I do sit within a housing authority, and I'd be happy to have a conversation with either yourself, Ben, or Heather, outside of this meeting, in terms of how we might be able to facilitate that joined up working, because I think it's really important. So please do feel free to come back to me. I saw Paul first, so I'm going to give vice chairs a prerogative, and then I'll take Colin.
Thank you very much, Chairman, and thank you very much for the presentation this morning. I've got one concern, really, and this is that we're looking at, we've lost some beds in the area, and we're looking at, I hear what you're saying, and I agree that we should be looking to keep people in their homes whenever possible, but I worry about the level of expertise and specialism in terms of having the staff available to follow that up, to provide that very valuable service. If we haven't got any inpatient facilities in Staffordshire, where is the expertise going to come from? That is my concern. I hope you could give me some sort of reassurance that there are plans in place for this to be mitigated. Thank you.
Ben, do you want to take that one as well?
Yeah, sure. So right now, what we've done on the learning disability and autism side of the population, we have a fairly large team of what we call PBS trainers. That's positive behaviour support. And their job really is to go and train and support the independent sector providers in terms of supporting. So we see ourselves in the future as being the bridge between where independent hospitals were, who would be expected to have the full range of expertise, to a different type of provider that we have now, where you have a community placement, quite a small provider, and lots of support from ourselves in the NHS and in social care in terms of training support and those highly specialist roles. So it's shifting the needs away from the independent sector to set up a full hospital placement, to setting up a community placement that can cater for folks' housing needs and day-to-day living, and we provide that blend and that expertise and that highly specialist roles to support them. So we see that shift, and then the independent sector, of course, grows its own expertise at a different venue.
Paul, do you want to come back?
Thanks for that. And thank you for your reassurance. I just want to sort of make sure that we've got our eye on the ball. I'm a director in the housing company in North Staffordshire, and I know that we've got plans for having mental health provision in some of the homes that we provide, and having that link with partners in the NHS and the private sector. So thank you for that answer. I feel suitably reassured. Thank you.
Thank you, Paul. Really useful conversation. Colin.
Thank you, Chair. Again, I just echo the thoughts as well as regarding the presentation. Looking at the risks and the key issues and so on, your face-to-face meetings have just, well, actually, there was none, and now there are limited, as it says. Can you just give us an idea of how they work? I mean, I understand it's face-to-face, but you understand how many people are there? Do you have a member of the family there as well? Because obviously these people are very vulnerable. Thank you.
Heather, if I may. So again, we're working with, I say we have a long history in the NHS of using something called care programme approach and CTRs, which is care and treatment reviews. And they are nationally recommended to have both the service user, the provider and the family involved. I say what we're working currently with NHS England on is something called the 5 Eyes approach. And I say that widens that group to very much place more emphasis on involving carers and family relatives. Quite often, these individuals have had some real family issues and don't have a family who are actively involved. So that's a bit of a challenge, of course. But I think between this approach that really does look at the whole spectrum of a support network for an individual and a contract with a provider, I feel quite content that we are learning from where things have gone wrong around the country, not just Elder Tree Lodge, in terms of understanding what our staff need to be doing to engage providers, to engage service users, and to engage whatever support network that service user may have or may need for the future.
Colin?
Thank you very much for that. Thank you.
Good. On the basis we've got a packed agenda, I'm not seeing anyone else indicating. Just wanted to summarise where I think we've got to. First of all, thank you, Heather and Ben, for really a clear presentation and supporting paperwork, made this morning's job significantly easier. What I think I heard was that post Elder Tree Lodge there is a long set of work that's being pulled together as part of lessons learned. You're going to share that with us when you get to that report that is also going to go to NHS England, that equally you are reviewing monthly with providers and that is face-to-face and will remain so wherever possible. You've got weekly visits going on. You've got a much closer contact with host providers where you've got people out of county. And that the policy is to try and drive in-placement down as much as possible. And that you're not just going to focus on the units, you're also going to focus in on the providers themselves. So I think all of that is really useful, and I just wanted to thank you for that. Is there any other comments that committee would like us to make, apart from noting the report and thanking our colleagues? No, on that basis, you're welcome to stay with us for the rest of the meeting, or if you've other more pressing things to do, please feel free to depart. And on that basis, let me move on to, thank you, Ben. Let me move on to item 5, the transformation programme. So this has been brought forward because what I was concerned about in the last couple of committees is there's a whole host of work going on across multiple strands of activity, and sometimes it's really important to be able to see the holistic overall overview rather than just the individual strands. Equally, I think it was important just to make sure if there are any interdependencies, I'll put my teeth in later on, if there are any interdependencies between programmes that they don't get lost. So Marcus, I think we're over with you. Who have you brought with us this morning, and welcome in any case.
Thank you, Chair. It's me and Jane Moore, who's my Executive Director of Strategy, Planning and Performance, and Tracy Shewan, Director of Communications and Corporate Services. I'm mindful of the fact that we've been here a few times, and we're here by way of update. There is a paper obviously attached for committee members to peruse, as well as a short set of slides that colleagues can have a look at. So I'll keep this introduction very brief, and then we'll open it up for questions and comments. The update paper basically covers some of the temporary service changes that we made when the pandemic hit, and those that still remain in place. Colleagues will remember that I think we came here on the 9th of August and updated on where we were with maternity services in the George Bryan Centre, and then on the 20th of September an update on the urgent emergency care changes and the difficult decisions programme. Also in the paper is a brief update on the community diagnostic hubs, which have been in the news recently and this morning, which is something we're currently working on. They weren't part of the transformation programme, they've come out subsequently, but they do link well with and support a number of the transformation changes that have been made during the pandemic and that we'll be consulting on over the course of the next few months or so. So I will probably stop at that point, Chair, and then happy to take any questions or comments on what's in the papers.
Thank you, Marcus. I'm not seeing anyone indicating early, so let me take Chair's prerogative then and just talk about face-to-face engagement. I know this committee has been very keen, and I'm sure Simon Fogel from Health Watch will be as well, has been very keen on trying to make sure that any resident in Staffordshire feels engaged. And there is probably maybe up to a third of people who don't choose to engage digitally. So I remain concerned that there isn't a plan for face-to-face. And I know I've written to you separately on this, but and you were on holiday, obviously, which is why I haven't had a response. But I'm just very keen to understand what NHS England's guidance is on this, because I would hate to find that the Staffordshire resident was excluded from a face-to-face when other residents in Gloucestershire or Lincolnshire or anywhere else around the country weren't. Could you just give us a view, please?
Yeah, certainly, Chair. Tracy, do you want to start this one off, and I'll add in if needed?
Okay, thank you, and thank you, Chair. Certainly, yes, it's NHS England's position that we are actually acting in accordance with what they recommend. We are obviously looking at what we can do going forward, and certainly as in this pre-engagement phase, we've checked out, as you're aware, with the Consultation Institute and NHS England, that we are acting within their guidance. And what we are doing is actually looking at how we can work with colleagues like Health Watch, like other members of the voluntary sector, to actually work with the groups in the community who meet face-to-face anyway, and the response is prepared in accordance with those sort of guidance that will come to you, Chair.
Does anyone else want to pick up this angle of questioning? The bit which concerns me is that it feels like everyone who is deciding the policy on face-to-face is in the same bubble. So they're all hearing the same thing, and as a result, no one's doing anything about the concerns that are being raised. I mean, I heard exactly the words that you said, Tracy, and it was very helpful. But, I would like to feel, we're all meeting in a chamber here safely. and we have been doing so since the 7th of May. It is beyond belief at the moment that NHS England is not advising any face-to-face consultation. Just let me bring Philip Atkins in, just may put it in English for me.
Yeah, thanks, Chairman. I went down to London on Thursday for a meeting that was hybrid. In fact, there were some of the people in this chamber who were on the hybrid bit. I have to say it's a lot better in person because you miss, when the screen goes blank, sorry Marcus, we can have a chat here and call you all the names under the sun, but you wouldn't be here to see that. And I think face-to-face is far better. I went to the East Staffordshire Health Scrutiny Committee and did a report in the last meeting and mentioned difficult decisions. Wow, that set a debate on. The chairman's here. I probably I arrived late and probably made his meeting an hour longer. So there's a little bit in the face-to-face meetings. I say that difficult decisions is not a very good title because all it does is set everybody up in a defence mode on their particular hobby horse, you might say, or their particular campaign. And they're going to say, well, we want everybody to have hearing aids. And then there were some very interesting comments about breast reconstruction and a whole host of other things that came out of it, which you get in a face-to-face meeting, but online you do not get because people perhaps feel embarrassed. I don't know, but I had a good time in London, and the only comment I'd make is you get closer to London, people started putting masks on, especially when you got below Milton Keynes and on the tube. But you know, there were 20% didn't wear a mask on the tube, but they were all of one ethnicity. I noticed on my 2 journeys, well, 4 journeys actually on the tube, which is quite strange. And you know, it was perfectly all right. There's no tourists in London, by the way, so you can walk around fairly free.
Maybe, Tracy, Marcus, you might just take this back to NHS England. I know that you're not disadvantaging Staffordshire's residents. Well, I don't believe you are. I mean, please shout if you are. But I don't believe you are. In which case, please, could you take this back on behalf of committee, if that is committee's view? I'm getting lots of...
yeah.
Sorry, let me bring in Simon Fogel, who may also just add to this debate, because I understand that you're not the policy makers in this bit. Simon.
Hi, thank you very much, Chair. It was just to tell committee that I attend lots and lots of systems meetings with our ICS colleagues as Health Watch is wanted everywhere, which is good. And we are forever championing the voice of the public, the patient, the service user, to ensure that as much contact engagement as is possible within the system plans is enabled. And I think in terms of the face-to-face appointment aspect of all this, it's very complex, I think, in that there are a lot of people who want that face-to-face, but there are equally people who want digital. And we're about to embark on a set of mini consultations, surveys, which we will be asking those questions in terms of what actually do people want. And that in itself presents problems because, of course, it's easy to push something out digitally. It's another thing to actually get out to community groups, etc., who aren't digitally enabled. So we probably will be asking support of councillors and parish councils to help us do that. But I think it was just to reinforce that from what I hear at all the meetings I do go to, an awful lot of work is being done to increase capacity, for instance, in primary care. And there is lots of issues in terms of staff retention, of course, because what we discuss here today in public can set some of the public up quite anxious in that they feel they are being prevented purposefully from getting face-to-face appointments, which then means the people who are the first point of contact receive an awful lot of abuse, hostility, and lots of those colleagues are leaving in droves. So that in itself then creates another problem when, even though investment has been put in, and I'm not fighting the CCG's corner here, I have to say, I'm just trying to present that middle ground as I see it, even though there's been infrastructure investment, if the people aren't there to actually operate the phones, it's self-defeating again. So I think there's an awful lot of work to be done, and one of it is to try and give confidence back to the public that everybody is on the same plate trying to do their very best, but it's not going to be an overnight panacea. And we as Health Watch will continue to take those messages to the ICS system.
Thank you, Simon. Really useful comments. Just let me bring in Philip Atkins, and then maybe we'll give Marcus and Tracy an opportunity just to respond to what they've heard. I've got Richard Cox and then Jill, but let's just do the Philip.
I was just going to say, my comment about London was, the civil servants aren't going into the offices. And that had dire consequences on people getting out of Afghanistan, because they weren't in the offices to expedite the necessary paperwork for the translators. And the very notion that we're having a discussion about whether in person or not makes people really anxious about what we are discussing. As just been said, they are topics. The title, difficult decisions. That sounds like we're going to stop doing something to me. And that obviously sets people off. There's an article I've read this morning about these things that we all carry around in your pocket. And if you lose this, how you are disenfranchised, because there's no clocks or watches. I haven't got a watch now, it's on this. If you try to make a direct payment, you'll have verification codes on your text message. So anybody who hasn't got a smartphone is automatically excluded. I've been on about this for about 12 years, Chairman, about the new illiterate, the people who can't use computers, and there's lots of them, and they're not necessarily old people. They can be a whole range of people who've, because of their hidden disabilities, cannot access these important consultations. Already we've taken time away from the content of the paper, which is diagnostic centres and treatment and everything else, and everybody wants to, they want face-to-face with the GPs and crowd out the surgeries and all the rest of it. But we do have to have a proper say in it.
Marcus, Tracy, can I just pass back to you for a comment, and then we'll just take a few more?
If I could maybe just start off, it's about balance. It's about striking the right balance. Tracy and I have been doing this for an awfully long time. And, pre-COVID, when we were consulting on a major service change, we could find ourselves, Staffordshire and Stoke-on-Trent's a very big place, sort of driving here, there and everywhere, spending 3 or 4 evenings a week talking to 4 or 5 people in a community centre or another venue. People would often argue about, I can't get to that venue, can't you do something more locally? Trying to make something local for people who maybe don't drive, that use public transport is incredibly difficult. So some of the feedback we've had around the way we've done engagement during the pandemic, well, really, we haven't been doing it all the way through the pandemic, so we haven't been able to, but when we've stood this up again, actually, some of it's been very positive in terms of people saying it's much easier to engage. I don't really want to drive to a meeting. I'd rather be able to do it online, view something online. And a lot of the feedback on our governing body meetings, for instance, is that rather than sort of having them in Leek, in Tamworth, in Stoke, in Cannock, actually doing them online makes them more accessible for some people. I do recognise the Councillor Atkins' comment around the digitally illiterate, or maybe people who, for some reason, can't use IT. It's about getting the balance right, and COVID's not an excuse; it's a reason for why NHS England are reluctant for us to do it. We've got nearly 50,000 new cases a day, and if you look at where we are across Staffordshire and Stoke-on-Trent, we're well above the Midlands and England average in terms of there's a lot of it out there. And also, we know that even if you've been double jabbed, particularly if you're an older person, that doesn't mean you are immune from getting COVID. And for someone who's over 80, who's been double jabbed, has the same risk as someone who's 50 that's unvaccinated. So we're still in the middle of a pandemic, and we're still trying to find a balance between providing easy access to our engagement opportunities whilst not putting people at risk. There is no perfect way of doing this, and we can do more face-to-face events, and we'll have people who want us to do it digitally. We'll do it digitally, and people say, but I want to be able to come and engage with you on a face-to-face basis. There's also, Chair, the carbon footprint issue. When we were doing the community consultation in Northern Staffordshire on the community services and the community hospitals, we would often be outnumbered we would outnumber the people doing the event, would outnumber the people who'd actually attended. And I remember one at Longton Hospital, we had one member of the public, and there was about 10 or 15 people there to do presentations, to manage the event, etc. So coming back to my previous comment, if we haven't got the balance right at the moment because of the pandemic, then we will do some work on that. But I think we do need a mix of opportunities for people to engage. And for many people, doing it face-to-face isn't right for them. They'd rather do it digitally. But we do recognise that for some people, turning up and speaking to people in the flesh, watching a presentation from the front is the way they would like to engage. So we will continue to work on it. We have got the balance right clearly for all colleagues on the committee, but very happy to work with you on fulfilling our statutory duties in a way that maximises access and input from the general public. Tracy, I don't know if you wanted to add anything.
No, thank you, Marcus. But we have learned a lot during the pandemic of how we've actually been able to engage with communities that perhaps we haven't reached before, and certainly around the vaccination, and how we can work with our colleagues like Health Watch in order to ensure that the public voice is heard. And we will carry on doing that, and do recognise the digital poverty issue that we do have if we only ever use digital. So thank you.
Philip, do you want to come back?
Yes, Chairman. You know, the last 14, 15 months I've had a really exciting time in farming. We've got lots of consultations going on. We're having the biggest change that we've ever had in our history since 1973 when we went in the EU. We're managing very well with webinars, face-to-face meetings and a whole host of things. You do not have to attend. You can have, like we have this. This has saved the carbon footprint. I can plant a few trees for you if you're really worried. That's not a problem. You can soon bash them in the riverbank. And but I'm just hearing waffle, and it needs to be going at pace with solutions and discussions. It's very difficult, and you always will have those at the front of the camel train and those at the back, and that camel train will get longer and longer, because there will be those that never ever do listen and will just react to the change, and those that will be at the forefront of the change. And when you're discussing things like the changes in health and deprived population and ageing population, the needs, improving life expectancy, all of that, you will have that lengthening camel train. I'm sorry. Now, do you move at the speed of the fastest or the speed of the slowest? That is the nub of all of these issues and discussions. And there are some that you'll never ever be able to help, I'm afraid. That's the nature of the game. And that is possibly why you ended up calling it difficult decisions, but I wish you'd called it something else.
Thank you. Let me just introduce Richard Cox and go from there.
Thanks, Chairman. I think Councillor Atkins is actually on my wavelength. And my concern here, Marcus, is within your presentation, I think you are still omitting those that aren't engaged through digital access. And we have to recognise there are a good section of our population that are just not engaged in that fashion. And we're still probably a generation away before we can probably say there's no excuse. But we're not there yet. And therefore, we must have that availability, because what worries me more than anything is the anxiety that people will have when they may think they've got something wrong with them, justifiably so. Sometimes it might not be. But what they do is they try and phone up for an appointment, which takes a length of time. Then when they get through, then it's all about a telephone consultation. Their anxiety levels rise. And invariably, unless they're so trained that they can actually detect it, it's often face-to-face that you actually recognise the anxiety in itself, because that anxiety then becomes visible. And you're not seeing that in any way or any fashion. So by not offering face-to-face, you're really putting a lot of extra pressure on the services that's provided by the NHS. And I think you need to speed it up, which is exactly, I think, what Councillor Atkins was referring to. Speed your processes up because you're running out of time with people's mental health and so forth. And I think it's important. Everybody's doing a great job, no question about it. But there's just one thing that we are now facing problems with. If we're trying to put the world back on a forward foot, we're not seeing face-to-face, certainly not in my area. And I don't think it's a concern. Thank you, Chairman.
Tracy, you picking that one up, or Marcus?
Yeah, just happy to comment that obviously today with the transformation, what we were talking about face-to-face engagement is actually during that pre-engagement, that sense check on what we had been told by the public pre-pandemic, which of course was through all our older methods, shall we say, in face-to-face. So this has been a sense check through surveys, through digital means as a part of moving forward with the transformation work. Take all the points, and certainly as we move through to consultation with the public, there will have to be that hybrid messages going out, which will be face-to-face and will be digital, and we'll have to learn the best of both going forward. I don't know if the councillor is referring to face-to-face contacts with general practice as well, but just clearly for this transformation part, this was about face-to-face engagement with the public, just doing that sense check on what they told us pre-pandemic.
Thank you, Tracy. Let me bring in... Richard, do you want to come back?
Well, yeah, no, I appreciate that obviously I might have drifted into GP access, but I think you could put it all together, in my view, in terms of transformation. And if there's a constant way wishing to engage via digital, you are missing a very big opportunity of engaging other people.
Thank you. Just for the benefit of committee will remember that we've agreed to look at GP access, which will include digital in December. I can't think of the date in December, but you'll probably know it more than I do. And second of all, we do have a slot in March to look at the use of technology, and this may sort of fit part of that discussion, albeit I don't want it just to be very narrow. Jill Hood.
Thank you, Chairman. Richard's echoed most of what I was going to say, but I will still say that we've heard the Health Watch rep say that there's going to be a consultation, and in my view, the Health Watch, who do an excellent job, their consultation will be with people who are easily contacted because they've probably gone through the channels of hospital appointments, doctor's appointments. So there's going to be a huge glut of people who are going to be missed out. My concerns about face-to-face, they are essential. Unfortunately, in my area, we suddenly have doctors' receptionists who have become medical experts and block appointments. I've said it quite often, I chair Age Concern in Stone, and I meet hundreds of elderly people. I sit with elderly people trying to get through to a doctor's practice, who are then grilled by a receptionist, and they're then told that they might get the doctor to call them. It just isn't good enough. A smile, eye contact, comfort. Mental health problems are becoming enormous with the elderly, and the elderly, Marcus talks about balance, but the balance in my division, the scales are weighted heavily for those who have access easily to the digital media. But it does worry me that the elderly who have conditions that have been going on for a long, long time just can't get appointments, and they'll see a district nurse come out to them, absolutely wonderful. She'll pick up the phone to the local doctor's surgery, get straight through, which is understandable, and which leaves the elderly person really perplexed as to why they can't do it. We desperately, desperately need face-to-face, both in our hospitals and in our primary care sector. Thank you, Chairman.
Obviously, this report is discussing the consultations going on at the moment, rather than necessarily face-to-face in hospitals or GPs. Is there anything, Tracy or Marcus, you want to just... I mean, I think you probably get a sense of the strength of feeling from committee in terms of the importance of engaging and using every channel available on consultations. I think that probably is the message to take from this morning. Is there anything you just want to add, Tracy, Marcus?
No, I think your initial question was very much around complementing the remote engagement and consultation work with doing a more face-to-face events. Yeah, we've taken that message away very clearly. We will do what we can around that. I think that the latter comment, which is around face-to-face access to appointments, outpatients, GP appointments, outpatients, we are coming back in December, I think, to do a much more detailed or have a more detailed conversation around what we've done and what we need to do around improving face-to-face appointments for GPs, for outpatients, etc. So I probably won't say any more on that. We'll wait till we come back in December. Apart from providing assurance to the committee that it is a top priority for us, it's a national priority as well. You will have seen, government ministers and the chief executive of the NHS being very, very clear that increasing access to face-to-face appointments with GPs is a priority. So there is a huge amount of work going on behind the scenes on that. And the experience that people have across Staffordshire and Stoke-on-Trent is variable. Some practices is much easier, some practices is much more difficult. Not because practices don't necessarily want to see or offer appointments, but there are some issues around workforce, the configuration of the practice that also needs addressing, and we are putting investment into those practices to enable them to provide a safe environment for people to be seen on a face-to-face basis. So there is a lot of work going on around that, Chair, and we'll obviously bring back a much more detailed report in December.
Thank you, Marcus. My learned colleague to my left tells me it's the 13th of December. Jill Hood, do you want to come back? So I saw an indication, sorry, Colin, you weren't up for, were you? Yes.
Thank you, Chair. I agree with my colleagues here, actually, regarding face-to-face. My worry is that we will miss people, and it's okay having a review and doing all the, you can review all you like, but eventually, some people, the time is running out, and I'm really worried that we are going to miss patients and people that are suffering so much and have suffered during the pandemic and beforehand. We all know that the mental health of people is linked to the mind is linked to the body. So eventually it will manifest itself in people worrying. Quite right. People do worry, maybe unnecessarily, but they do worry, and it is so important that we start this face-to-face consultation. I know we're going to maybe talk in December about this, but we have to really push it all the time. In my opinion, carbon footprint. I must say, carbon footprint. In our area, we're having a real issue with in East Staffordshire. We're having a real problem with possibly a closure of a Stretton surgery. Now, Stretton is quite a large community. It's a very large community, in fact. And then they've got to go to Branston, which is 4 miles away. So if you're thinking about the carbon footprint, maybe you should keep one surgery open. I know we're going to say we'll talk about this in December, but just think on those lines, please. Thank you.
So I do want to bring this part of the discussion to a close because I think we're really giving it a good old beating. I did notice that there is Philip. Do you want to come on to a different subject?
On a separate thing, on page 33 on the mod.gov agendas, it's page 35 on mod.gov, it's page 33 of the papers, is the different steps. The first, the essential criteria, second step, desirable criteria, and then finance is separate process, applied later in the development of the proposals. Wow, we never do that in local government. We have to cut our cloth to what we can afford. So when you don't have finances in, you can come out with a massive wish list that you can't afford unless you stop doing something else. And that's why we've ended up with this 2% on national insurance and nothing coming to social care. Finance has to be an essential part of it, even if to explain what you can or cannot afford when you're trying to go through the essential criteria and building it up. We have to have 3-year financial strategies here. I know the NHS goes on a different one. At the end of the year, they just shuffle the pack and the Treasury gives them the money. But we need a little bit of financial stability. And that isn't cuts. That's making sure that the cake goes around where it needs to be fairly. Because what we found here 10 years ago, there were some bits of the local government family were quite bloated in what they were doing and we were paying people to do what the communities were doing themselves. For example, pharmacies could do a lot of things that are already in GP surgeries. So some of it is back to the discussion papers about treatment centres and diagnostic centres. But please don't put finance at the back of it. Explain somewhere along the lines that this will be more efficient and more effective in delivering real outcomes to real people who live in Staffordshire. Sorry to be a bit, you know.
So this feels like a Marcus question, albeit I'm sure Marcus isn't here to defend government policy. So I'm not going to ask him to pick up that element. But could you just pick up the financial point that Philip's made, and then we'll go on to Janice.
Yeah, sure. Jane, did you want to just pick that one up?
So can I just confirm that no option that goes out for consultant can go out that is not financially viable. So we are required to show that all and when those schemes are looking, one of the key components will be around the cost effectiveness of those options in terms of the maximisation of benefit for the cost. So we absolutely have to demonstrate that these are financially viable options for them to go forward.
Philip,
yeah,
does that assure you?
Just come back on that. You know, sometimes what we found out in local government is it takes a long time to make the case, and particularly with health, because people get better over a longer period of time. Infrastructure projects are a classic, where you put the money into a project like I-54, and it gets paid for by the business rates over 10 years. I've always gone along with money's never a problem. Paying it back is. And if you go over a longer period, 3 to 5 years, you will show benefits. That's always been the politicians' problems. They all know what's got to be done, but they've got to get elected again in 2 or 4 years' time. National Health Service doesn't have to do that. So, you know, we need that perspective in the finances. And it would have been nice to see that if we have people that have got hearing aids, then the chances of dementia are significantly reduced, which they are.
So that's why it has to be a cost-benefit analysis. So we absolutely do make sure that we absolutely look at the benefits from a population perspective against that financial requirements, but they do still have to be financially viable options to go forward under the NHSEI guidance.
Thank you, Jane. That's helpful. Can I bring in Janice, please?
Thank you. I'd also put down a question on where does finance actually appear in this process chain. From the slide, it looked like an afterthought, so I'm reassured now that that isn't the case. Just going back to the consultation side of things, where we got information about the amount of respondents, I thought that was particularly helpful. So we can see how many people are actively engaging in that consultation, whether they're online, digital, would also be some help. I take the point that, you know, with a face-to-face, that there were lots of people, experts in the room and only one member of the public. I'd also like to question then how that was actively promoted as a separate one. But I just think it's useful to be able to see, is it the same people that are responding time after time that we're asking the same questions of, because those are the easy ones to contact? And also, if it is making a difference as us as local members, when we're given the information to say, can we pass this on to our district colleagues or our parish colleagues, that there's any more involvement on a wider basis when it comes down to these extremely informative consultations. You know, they are the part that then forms the basis of what comes next. Thank you.
Tracy, is that with you?
Yeah, thank you. In terms of responses, it isn't always the same people. Certainly we look at the survey responses, and on urgent and emergency care, we're well over 300, as we are on some of the difficult decisions. And what we also can do through that is actually check on our demograph. And what we do with any of our engagement work is we look to see, are there areas that we haven't been able to reach, and what targeted work can we do? Because not always people want to talk to people from the NHS. They actually have more confidence talking to other people, and that's what I meant by us working with partners. So we do check out where we're getting our responses from to make sure that we do look to people who are perhaps not being accessed, look at a certain group, certainly look at protected characteristics, and one of those that we've added to that is those that have digital poverty. So we have picked that up. We haven't got it right yet, obviously, and we'll take all the feedback that people have said, and yes, we will have all the details as we go forward of what people have said to us, and collect all that information and share it.
Yeah, I think it is just that helpful side of being able to look at how many are actually responding to those particular topics, and if there could be some type of split as well between those that are met face-to-face and those that are accessed online would also be useful. I appreciate the points that made about the demographics that are being specifically looked into in the detail, but yeah, I think there's probably more that we could put into some of those informations, just so as we have also a good idea of the amount of people who have been involved in that consultation. Thank you.
Yeah, thank you, Councillor, and we'll include that in our report of findings, which we do after each set of engagement.
Thank you. Really useful discussion in terms of using the data we've got. It reminds me that the access to your past and current service users I think is restricted, and you don't always, from a response I saw on, I think, the George Bryant consultation, go back to your previous service users. And it does surprise me that from a GDPR point of view, you haven't resolved that really quickly, because who best will know about services than those people who are either in services or been through them. So maybe that just could be picked up. I'm sure it's a data protection issue, but come on, guys, let's resolve that. Janice, are you done? Richard.
I just wanted to endorse what you've just said there, Chairman. I think it must be 2 years ago at Lichfield District Council, sitting on the Health Committee, that I made reference to, obviously, the consultation, to consult with those patients, and more in so families of those patients. And of course, GDPR was your sticking point, and yet that is where your real help will be available in the whole process, those patients and, more importantly, their families. Thank you, Chairman.
At least it wasn't just me who picked it up. Do you want to make any comment, Tracy or Jane?
I can pick that one up, because certainly we're working with Midlands Partnership Foundation Trust to manage those services, because they can actually access their past service users and their current service users to ensure that they are involved and informed in the engagement.
And I was just going to iterate the same, that on all of these we do work with our colleagues in the provider organisations who can access the data to try and make sure we are picking up those service users.
Okay, let's hope as consultations progress that we don't have the same conversation, because sometimes these little things turn into Groundhog Day. Can I just make 2 points in closing, because I do want to move off this topic, because I'm aware of some time pressures. Just two small points, just in terms of the slide which starts with a case for change. I think it's a nice graphic that you have there. I think the words are really good. I would just like to see that the middle bullet, instead of saying improving life expectancy, which is always helpful, actually said improving healthy life expectancy, because actually until we resolve that issue, I think that just extending people's lives, because I think we've done that really well over the last 5 or 10 years. What we haven't done is improve people's healthy life expectancy. So just as a minor comment. And the other comment I'd make is the slide which looks at the timeline for I guess it's a Gantt chart, is it? But the timeline for all the consultations. I just note that there isn't some of the other consultations like the Leak Hospital developments on there, and it would be just useful maybe to pull up all of those. I know that's maybe outside of the remit of this discussion today, but it does then show the quantum of work that's going on, so that we as a committee don't miss anything within our scrutiny. I'm not seeing any further indications. I do want to move on, so I'm going to do that. So let me just thank you, Jane. Let me thank you, Marcus. Let me thank you, Tracy. I think the conversation very much focused on one area, which was really about making sure we don't exclude anyone, and I know that is top of your list, and I think Marcus's words were about it's about getting the balance right, and maybe committee don't feel that is fully the case at this moment, and I would encourage you to take that back with committee's recommendation to push back to NHS England. I'm not seeing anyone dissenting from that position, so let me bring to a close that element. Let's move on to item 6, which is performance dashboards. Little comment to preface this item. Members will be aware that I've been very keen to create a dashboard which demonstrates performance that we can look at quarterly, and it's only taken me 15 months to get this far, so it's only partial, so I don't take it as a success yet, because we do need to incorporate something that looks at social care as well as NHS performance. But I'm also keen that we don't create an industry of measuring stuff that no one then reads or does anything about. So I think it's about balance. But I would always refer members to what one of my original bosses all those years ago would say, which is actually people do what's being measured, and it's sometimes quite useful to be able to have those yardsticks so that we can fully scrutinise the work that we are due to do. Marcus, can I pass over to you and Jane?
Yeah, thank you, Chair. Same approach on this one. There's a short report with a dashboard with some of the sort of key metrics that we measure and monitor on a regular basis. The report focuses primarily on plan care, on referral to treatment times, which is the time from a GP for a referral being received by a provider and a person actually being seen and having the first definitive treatment. There's also some data around diagnostics and waiting times for diagnostics, cancer. There are various different cancer metrics that we use to measure performance across all of our providers and the experience our patients are receiving. And then there's some information relating to the urgent emergency care system and winter pressures and preparations for winter. I would just remind colleagues, not that you need reminding, that we are obviously still in the middle of a pandemic. Case rates are increasing, admissions to hospital are increasing, and whilst the vaccine has been incredibly helpful in terms of preventing things getting much worse now than much worse than they could have been at the moment, and whilst we're nowhere near where we were in the winter, where we had I think 5 times as many people in hospital and 10 times as many people dying from COVID, we're certainly not out of the woods at the moment. So COVID is one of a range of pressures in the background that are really impacting on getting back to some semblance of normality when it comes to GP access, referrals for treatment, for elective care, plan care procedures being carried out. So we're still in a really difficult position. We've got I've worked at the NHS for 31 years now, and probably we're going to be facing one of the most difficult winters we've had. So really in a difficult position, and that's very much reflected in the sea of red that you'll see on the dashboards. I'll probably pause at that point, Chair, and I'm sure there'll be quite a lot of questions around the data that's in the that's set out in the dashboards that you want to ask us about. And as I said, Jane is my Exec Director of Strategy Planning Performance, and her team produce these reports, which aren't just for the purposes of this committee's deliberations, but also go to the CCG's governing bodies and its Finance Performance Committee on a monthly basis, and also to the Integrated Care System Partnership Board. Thank you, Chair.
Thank you, Marcus. I'm not seeing any early indications, so just let me make 3 comments. One is obviously that come April next year, we will be into presumably an integrated dashboard, which will be 1 rather than 6, or maybe 2 rather than 6. Second of all, I do take your point on the difficult winter ahead, and that was a purpose in part of getting every part of the system, whether it be GP access or secondary care or social care, all in the same room for the discussion on the 13th of December. And the real point here is really trying to get a transparent view, which then looks at how the individual indicators move over time, because I think that's probably the interesting thing for committee, is to see the progression over time. I'm hoping that someone might want to come in. I've got Janice. Thank you for rescuing me.
You're very welcome. It's just reading the charts, I can see that we've got some RAG rating on here, the red, amber, green type. But you're right, it's the period over 12 months that for me gives me the most useful information. So the first part that I was looking at was the healthcare acquired infections, for example, with MRSA and CODIF. I would assume that whilst we've had no visitors to hospitals predominantly, whilst we've had the level of PPE that we have, that would have had a significant impact. So just for my own understanding of here, looking at that rolling 12 months, is that actually the case? And then I can apply that same premise for all of the other data then that follows. Thank you.
Jenny?
We look at this data over the 12-month period, April to March the following year, and this is an indicator in terms of the expected levels and of MRSA, which should be 0 basically. So that has been maintained over the period. Of course, the infection control and lack of visitors probably has had a beneficial impact on that, but actually it's about good infection protection control, which all our trusts should be enacting, whether COVID is in existence or not.
Janice, do you want to come back?
Thank you, yeah. As I say, I can apply that same premise for how it goes on afterwards. There's obviously a lot of data here in that particular dashboard that we're looking at Appendix 1, and applying that same premise, I think, will be helpful going forwards. And I think looking at the different areas as well, and also ones that are on our neighbouring pieces, is also useful. So I think it would be interesting actually as time goes on to be able to see how effectively we can use that, because I can see that there's a lot of effort that is going into it, and you're absolutely right, we need to make that meaningful. Thank you.
And one thing we can do for you is that if we produce this quarterly, we can do whether the arrows from now going forward, we can do arrows going up and down. So has it changed positively or negatively since the last quarter? So that would probably help. Though we do actually give you how it's looking over the year months in terms of the section of the dashboard to try and help you understand how it's looking over the 12-month period, the performance.
Chair, just one thing to add to that is the 12 months rolling data is really important, but it's also important we look at pre-COVID, because obviously for the last 18 months we've been in the middle of a pandemic. So it's also we also look at where were we before the pandemic rather than just measuring the last 12 months. But trend data is more important than the spikes you'll get on a day-to-day, week-to-week, month-by-month basis. So yeah, to be fair, I look at the trend first rather than what's happened today or yesterday. That's more important. But we can't lose sight of the fact that from a restoration recovery perspective, you know, where were we before the pandemic struck? And that's where we probably need to get back to in terms of things like, you know, access times. We have no patients waiting at all at none of our patients at any of our providers more than 52 weeks for a procedure. Just at UHM at the moment, it's over 6,000. So yeah, we're in a very, very different position now to where we were pre-pandemic. We obviously can't lose sight of that.
I welcome those comments, Janice. That's fine. I'm not getting any other indications, so just let me make a couple of comments. One is we probably need a financial dashboard, because I think that's what Councillor Atkins would have asked for a minute ago, and we shouldn't lose the point that he made. So maybe that's a bit of work in progress for us all at some stage, because it just needs to be simple and easy as a sense check. But I think this is a really good report. Jane, Tracy, Marcus, thank you for that, if only because it helps us build towards that overall dashboard of health, Staffordshire's health across the county, and it gives committee something to be able to see progression. And obviously at the same stage it allows us to roll this down into the districts and boroughs, not so that they can scrutinise this, because that is not their role, but it does allow people to be able to say, what are we doing individually to improve the health of our individual residents in our own borough or district. To that point, I should have made the point for committee also just to pick up their own role in taking consultations down into districts and boroughs, because it isn't just Tracy and Marcus and Jane's role to do that, it's also ours to make sure it does land everywhere. And the last thing I'll just say on this, I know you want to come in, Jane, the last thing I'd say is I welcome seeing the GP access data. GP access is a real issue for many of our residents, and actually being able to see something and chart that is really helpful. So thank you for that. Jane.
Just to say 2 points. One is that we are working across the system at the moment around getting better integrated performance, and I'm leading on that work to try and make it real, so it isn't just that it's a load of data, but it's actually being used for people to ask questions and try and improve and think about what we can do differently. Linked to that is that as part of that movement to systems, there will be a new system oversight framework, and so some of these indicators will change over the next period, but we'll try and make sure that the links between the old data and the new. And the third point is absolutely what we want is that this is information that's useful for people. So any feedback or things that you would like to see that would help it make it more real for you, then we're very keen to have that information to support this to be actual information that helps us understand and make change happen, not just that it sits there on a page.
Welcome those comments. Thanks to you, Jane and Angela.
Thank you very much, and thank you for your presentation. My question really is, looking at this chart, is the concern regarding cancer breast symptoms, 2 weeks, and it's such a low average compared to what it should be. Is there anything what we're doing to improve that, please?
Yes, it's an issue across the region. It's being looked at across the whole of the West Midlands through the West Midlands Cancer Alliance, as well as locally. It's a really interesting indicator, because a lot of because breast cancer, breast symptoms are very widespread. So there is a lot now happening. We're setting up different pathways for these patients to be seen. We're setting up work within the community. And we are doing a lot of shared learning across the region about how we do this, because this is an issue not just for us in Staffordshire and Stoke-on-Trent. So it's a really good point, and is an area that we absolutely know that we need to look at new and innovative ways to get women through this pathway.
Thank you, Anne. I know you don't want to come back. Just let me, in closing this area, I think it's really useful, because what it allows us to be able to do is to focus in on those key areas going forwards and those areas of concern. So thank you for bringing this forward, Marcus, Jane and Tracy. Really useful starting point. Understand that it will evolve over time, but I appreciate the work that's gone into that. And we will see that improve through not necessarily Marcus, Jane and Tracy, but through Richard Harling and his team to add in the public health elements. With your permission, we should note the report and thank the authors, and move on to item 7, which is, Marcus, you're welcome to stay, Tracy, you're welcome to stay, Jane, you're welcome to stay, but we're going to move on to item 7, which is Wally's Quarry update. We've got a whole range of different partners. We've got Claire Dinnis from the Environment Agency. We've got who's leading on this piece, and do you want to introduce the whole team? That would be a bit easier. Emma, are you leading on this?
Hi, I think it's in two parts actually. There's first the report that I've done on the various surveys, and then I think colleagues from Public Health, UKHSA and Environment Agency will be doing the second part. Do you want me to introduce everybody, or should we just go around and introduce ourselves? I think it's probably easier, isn't it? If I go first, my name's Emma Sambach. I work for Staffordshire County Council as public health consultant. I also do 1 day a week for UKHSA. Claire?
Thanks, Emma. Good morning, everybody. I'm Claire Dennis. I'm the Area Director for West Midlands for the Environment Agency.
Okay, Mark?
Yes, good morning, everyone. My name's Mark Liddoff. I'm the project exec for the Wally's Quarry project team at the Environment Agency.
Okay, thanks. Alec?
Thanks, Emma. Yeah, good morning, everybody. My name's Alec Dobney. I'm head of units for the UKHSA's Environmental Hazards and Emergencies Department.
Okay, thanks. And Ovner?
Yep, good morning, everyone. Yeah, I'm Ovnaya Sepai. I'm the group leader for general toxicology and supporting UKHSA on the toxicology side of things. Thank you.
Okay, shall I go through the report I've done first on the health surveys, and then colleagues, because it's quite quick, and then colleagues from the other organisations can go through the next bit, which is an update on the sort of works and stuff.
Sounds like a good idea. Please, Emma.
Okay. Sorry, it's a bit confusing with everybody on the screen. Basically, my role with the council and UKHSA, I've been trying to look at the sort of health of the local population and the impacts that could potentially be caused by living in a close proximity to Wally's Quarry. So I'm not sure how familiar you are with health data, but a lot of the information we have is quite out of date, and often the public health population data looks, usually is sort of a year and a half behind. So what we've tried to do is collect some more recent information, and I'm not sure how much you're aware, but the County Council in Staffordshire have set up a smell and symptom tracker as one way to do that. So basically it's a way of local residents being able to log on and record what symptoms potentially of health that they are experiencing, and also odour complaints and the intensity of that. However, we were aware there's a number of other, excuse me, I've got a cold, different survey reports that various different people have produced. So what I've tried to do is pull together all the information where it's possible into one report from all the various surveys. So just to give you an outline, there was a survey done on health impacts by Aaron Bell's office. This is all in the paper, so you can see there was also a health impact statements collated by Newcastle Underlyne Borough Council. And then most recently, there's been a community health survey, which was produced by a local member of the community, and as part of, I think, a group that they have around the quarry. So just a quick overview with these surveys, all of them, including our symptom tracker, which is the symptom tracker is the only one that reports things on an ongoing basis. All the other surveys have been done at a point of time, and they are all self-reported. So, that there's an element of bias will come into each and every one of those because of that. All the surveys are quite different, so they ask questions in a different way. So whilst I've tried to compile the answers in similar categories, they haven't been asked in the same way. So there is a difference in that, and it probably affects the amount of people reporting each of those. Plus, they've all been done at different times over the duration of the problems from Wally's Quarry. So again, whilst something at the beginning, people who answered that, the responses may be different to what's going on now because of the changes in what's happening in the quarry. So I've basically done a breakdown on the paper of the people who've responded from this, and that varies. So for example, with the latest survey and the Aaron Bell survey, there was sort of 1,400 in Aaron Bell's, 1,800 in this latest community one. Health impact statements, there was 800 of those. There's been over 2,000 responses on the smell and symptom tracker, but just to point out, that's cumulative. So that could be the same person answering every single day as opposed to individuals. We've found basically that a lot of the results from each of the surveys correspond with one another. So the majority of people who've responded have come from within 3 miles of the landfill area, with almost half of those living 1 mile from the landfill area. And we've used that information to produce sort of a map which maps out where the majority of the respondents are, so we can look at which areas obviously having the most impact, or people are reporting the most impact. Again, the latest survey by the community has also done that, and it roughly maps out the same areas having the same levels reported of symptoms, or for the other surveys, the symptoms and smell tracker, and the MP survey, odour nuisance as well. Just to point out, the latest community survey only included information on health symptoms. It didn't ask about odour. So, like I said, that most of the people who are living near the site have reported very strong or strong levels of odour nuisance. Excuse me. If I go down to the symptoms, I think if you've got a copy of the report, I've produced a table where I've tried to sort of cross-reference everything.
Emma, can I just interrupt slightly?
Yeah,
we have had this through committee previously, so it was just the summary of the update that I think that we probably needed.
Oh, right, okay, I didn't realise that.
And it also allows Claire, who needs to go at midday, just to be able to bring her summary, because I think we're sort of probably up to speed having read the report, but if we just pick up the summary, that'd be useful.
All I've done is updated it to report the latest community figures from the survey that was reported in that. So from what I can see, pretty much everything was the same. The only thing that was slightly different on this was there was a higher reported level of mental health problems related to the landfill site. Now, that could just be reflective of the community. It is self-reported, so it could be partly at the time it's done. However, it might be reflective of the fact that it's been going on for a longer time, so people are getting more anxious about it, and that's something that we need to consider as well. Again, like I say, it's self-reported, so you can't be 100% sure with all these things. So really, you can see the table there. I've added everything in. And other than that, it hasn't really changed the conclusions of the survey very much at all. So if you're happy with that, that's pretty much my section done, and colleagues from the other organisations might want to present theirs.
That's clear. Thank you, Emma. Appreciate that, particularly the clarity in that not much has changed since over time. So who is leading from the EA on summarising All Public Health England? Who is leading on this?
Yes, Chair, that's me, Mark Liddeth. So yes, hello everyone. So just to give a brief update with regards to since we last attended the Scrutiny Committee, many of you would have seen that on Thursday the 14th of October, the Environment Agency published our plan, which was around the reduction of hydrogen sulphide emissions from Wally's Quarry, which is the landfill site that is operated by Wally's Quarry Limited. Now that plan already builds on the extensive regulatory work that we have already done to date with regards to the situation, and it outlines all the measures that we are designing and applying as the regulator to the operator to implement a number of complex actions to be continuing to deal with the hydrogen sulphide gas emissions. The plan describes, what I mentioned at the last committee meeting, which is our strategy around the contain, capture and destroy. And so there's a number of work that's going on at the moment at the site that has been following the strategy that was set in place. So with regards to the contain work, the posi shell, something that was mentioned at the last committee meeting, and the members who were there and obviously would have seen from the minutes that there was some delays with the arrival of that posi shell product. That has now all been deployed and applied on site. So that work has been completed, and that has meant that we have now got an additional 20,000, roughly about 20,000 square metres of the landfill temporary capped with that product. So through that action that we've got the operator to do, that is now taking it to just under 70% of the site having either a permanent or temporary capping surface. And all that capping is all to do with the contain. So that's about containing the gas, so no fugitive emissions escape to the atmosphere. Alongside that work that's currently in operation at the moment on site is around the strategy part about capture, and that is where the wells on site are being drilled. So in total there are 28 wells that are being put into site. Some of those wells are going into existing waste to capture gas. Some of those wells are being put in for future waste that's going in. And those 28 wells, we have got 20 installed with the operator. So the operator has already got 20 of the wells of the 28 installed, and they are still on track to have that completed by the end of this month. So all 28 should be in. What's happening is that every time a well is put into site, that is capturing, connected up to the pipe infrastructure that then leads to the gas utilisation plant. And so that's obviously capturing gas every time a new well is connected. So what we are seeing from the gas capturing figures, so where we were probably around about November, December last year to where we are now, we're almost seeing double the amount of gas being captured and sent to the gas utilisation plant, where that is either converted into energy from the engines, or it is destroyed through the flares. And through that operation, that is obviously part of the third part of the strategy, which is around destroy. So the efficiency and the effectiveness of that gas utilisation plant is being closely monitored. We served notice on the gas management contractor that works on behalf of the operator to install continuous telemetry onto the gas utilisation plant, so that could give us real live data around the effectiveness and efficiency of that running of that equipment. And if there was any issues with it, we'd be able to see that through the data and then instruct the gas management company through the operator to make any necessary changes to ensure that the gas that's being captured either through the flares being destroyed through the flares or through the engines is running to best effect. So the UK HSA health risk assessment for August 2021, which I know my colleagues from UK HSA will cover in a bit more detail, the records between March and August, so March is when we first installed our air quality monitoring units, and up to August, it's showing that the hydrogen sulfide levels that are measured against the World Health Organization, so that's the 30-minute average odour annoyance guidance levels, have been falling month on month. So since March to August, they are falling month on month. So we are seeing, significant reductions in those gases being produced, but we are obviously appreciative that there are still issues being, felt through the community from outside the site boundary, and we continue to take a very strong regulatory approach to ensure that we are getting the operators to continue to do everything they need to do to reduce those emissions. I will pause there, Chair. I don't know if Claire, if there's anything more you would like to add from our perspective.
Thank you, Mark. I think the only thing to say is that I'm sure members will be aware that we have held the first of our face-to-face engagement sessions, which we think is a really important part of dealing with the mental health impacts of this, as well as the physical health impacts, so people can hear directly from all of the partners that are involved with SCG, the strategic command of this. We had about 160, 180 residents through the door over 2 events that were held on consecutive weeks, a mixture of responses, and we've done some evaluation that we're looking at and planning to do some more. But generally, people told us that they were pleased to be able to ask questions, hear from us directly, and they thought the events were worthwhile.
Thank you. That's useful. Are we on to I can't remember what Public Health England is now called, but you know who I'm talking about.
I do indeed. Thank you, Chair. It's Alec Dobney here. And just to say that I think at the last committee meeting, it was members from the team from Public Health England. As of the 1st of October, we have transitioned into the UK Security Agency, but just to assure the committee that it's exactly the same scientists and staff that have been dealing with Wally's Porry and supporting the multi-agency meetings that are still doing that now. So we have very good continuity. And thanks to Mark and Claire and Emma for their updates. So the committee will be aware that we submitted our latest August health risk assessment for the committee to review. And if I just pull out a few of the headline parts of that, and then we're very happy to take some questions. So the hydrogen sulfide data up to the end of August, as Mark has mentioned, has showed continued exposure to the population around the site, albeit concentrations in August continue to decrease month by month from those seen from March through to July. And additionally, at 3 of the monitoring sites that the EA note air quality from, they are now below the long-term lifetime health-based guidelines value. So, as a result of that, currently any risk to long-term lifetime physical health is likely to be small. However, we can't completely exclude a risk to long-term health, where exposures are still above that US EPA reference long-term health-based guidance. And that's the case for one of the sites, still at Gallingale View, which is just east of the site, albeit at that site, the concentrations have also been coming down quite significantly. To assess the concentrations and the exposure to health over this year, so that's 2021, we set a value using the ATSTR intermediate minimal risk level. So this was for a year, this was 14 days to 364 days, which runs from January 2021 to December. We set it for that year because of concern that even though we hadn't got monitoring data, we knew that there was some exposure from the beginning of the year. And that's set at a value of 30 micrograms per cubic metre, and that's not been exceeded. So again, there's confidence there that any risk to long-term physical health is likely to be small. At the end of December, that then reverts to this US EPA lifetime concentration value of 2, which is set out in our risk assessment. As Mark has also noted, concentrations of hydrogen sulfide around the annoyance value. This is a guideline set by the World Health Organization for odour annoyance, and this is set at 7. And there's still, certainly in that August evaluation, a considerable percentage of the time where it's over that value, albeit that is also coming down. And again, that's at one of the sites, and that's undesirable due to the effects on people's well-being and the symptoms that they are experiencing. So they're just the headlines from our August assessment. It's always available each month once we've produced it and published it, and that's always available on the citizen space of the EA site. I'm happy to take any questions.
Thank you for that summary. Very useful. Janice, let me bring you in.
Yeah, thank you. I've got a couple of points, and I'll try and condense them into some type of sensible order. First of all, with the surveys, I took opportunity when we had our last meeting up at Newcastle-under-Lyme to go and visit the site of MMF9, and it's quite clearly amongst a lot of residential areas, and that's the one where predominantly the parts per billion are being exceeded. As far as the surveys are reporting, I understand for impartiality that self-reporting, it has to be acknowledged, but equally I would also say the mental health impact of knowing and experiencing that day in, day out shouldn't be undermined because of that in any way, sense of order. The fact that we've had the media reporting the High Court outcomes, the fact that statements are made that impacts to health are unlikely or likely to be small would all not help in terms of people's own mental health issues when they're looking at, are they safe, are their children safe in their own homes during an extended period where people are likely to be spending more time at home. So that would be my first very clear point that I'd want to make when it comes to the reporting of mental health in those surveys. The second part, and it's been useful to have the update about the amount of capping that now is being successful there, but in another question, I would still want to know, are we satisfied that what actually has been deposited at that site that is producing such obnoxious disturbances of what was supposed to be, what the permits were for, what the licenses were for? I understand that the capping is that temporary part that we needed to remedy an immediate solution. But is there also any impact onto the water course in there? So whilst we're focusing predominantly a lot on what's going out into the atmosphere, is to maybe something as well that might be going into the ground that could cause another problem in the not too distant future. Thank you.
Feels like an EA question, certainly the last one.
Yes, Chair, I can pick that up on the 2 points raised there around what's gone into the site and the water quality. So I'll come to the water quality one first. So in terms of a landfill site, there's obviously kind of construction methods that have to be used to ensure that there is no infiltration of kind of water that gets into the groundwater supply. And that, you know, we're confident in terms of what's been put in place in that landfill site isn't causing any impacts to local water courses or the water quality. And we actually have equipment actually in the local brooks beside the quarry itself that's obviously monitoring the water and anything that's going into there. And we've had those in there for a number of months now, and all the data that's coming back is not showing any kind of pollution aspects coming from the landfill site that's getting into that water. So, and those monitors will obviously stay in place as well. So we'll continue to monitor that. With regards to the material that's gone into the site, so what produces hydrogen sulfide is kind of gypsum kind of material, heavy base gypsum material that goes into site, and that would have gone into the site at some point. Now, what we have done with the site itself in terms of their permit is that there is very strict rules around the permit conditions of what they can and cannot accept, and there is in the permit conditions itself is a very strong line about the not being able to accept gypsum-based materials. And there's a lot of work that we have done with the operator to ensure that all the pre-acceptance of waste going into site is dealt with, and that checks are made through sampling to ensure that there is no gypsum-based materials going into the site that would cause future issues around hydrogen sulfide. So we are continuously monitoring that, and some of the work that we are also doing is we're actually also looking at where the waste is coming from. So it's not just when the waste arrives at the landfill site, but it's actually from the waste producers themselves. So what we kind of call upstream checking and measures, so that we go and make sure that those waste producers are adhering to their permit conditions and making sure that the waste that they are sending to the landfill is the right and appropriate waste.
Yeah, thank you for that. I think it's worthwhile having some of that information as well that we can access in future times as well, especially when it comes down to the water side of things. It's good to hear that that's being monitored, but equally I'm sure that there was confidence in lots of other systems that were set up at the beginning which didn't then materialise. Thank you.
Jill Hood.
Thank you, Chairman. I've looked through the report that we've been sent, and obviously I watch the television, listen to the radio. Everything is centred on health, which admittedly is really, really important. Mental health, physical health. Nowhere have I seen anything which reflects on family breakdown. Possibly it could be fitted into the mental health impact, but I just wonder, has anyone done anything at all about the impact on the community, the breakdown of families, what's happening to these families? Are they having counselling? Is there anything that we can do now? Is it too late? Surely it's going to be ongoing, and it really, really worries me that there's not a mention of how the impact is affecting families and what we're actually going to be doing about it. Thank you, Chairman.
Emma, over to you.
Hi, it's not something that I think's been raised as a specific question in any of the questionnaires. And at the engagement event, we spoke to a number of people. It wasn't anything that was fed back to myself or colleagues either. But if it's something that is of concern, then maybe, if we're looking at doing any more surveys, that would be something we might want to ask. I know CCG have set up a counselling service or a mental health service specifically for that area for people who live locally, because they're aware that it is causing a lot of stress for people, and I think like I say, we've done 4 surveys. Well, not say we, I'm talking about various organisations, including Staffordshire County Council and the local community. And the consistency between the reports is you know, strong. They're all saying the same thing each time they've been asked. So yeah, that we are aware of the mental health issues, and that's something that is being taken seriously.
Thank you, Emma. Just before I bring Jill back, could you just confirm to us the scope of the Keele University work? Because I'm pretty sure there was a study survey that was going to be undertaken by Keele that we talked about last time.
Yeah, that's right. That's probably a longer term piece of work because it's a proper piece of research, and that'll be looking at GP data and records of people who've been accessing, you know, ringing the GP, accessing the GP for appointments and the impact there. So I've done a little bit of initial work, which hasn't been published yet because it's still being finalised, looking at prescribing rates for particular things that would potentially be related to living near the landfill site. But this is looking at actual attendances and appointments and stuff that's being given out. I haven't been to one of the meetings for a while because they clash with our STAC group, which I have to attend. But I think they're just sort of finalising some of the issues around data sharing, looking at what's being included. But as far as I'm aware, that is going forward, and it will be, I think, a really useful piece of information to understand what's happened in terms of rates of attendance at GP practice. It's really difficult to look at. I mean, we've looked at the syndromic surveillance that UKHSA collate for the local area, but it's just not sensitive enough to pick up any issues around the particular area of Wally's Quarry, because it looks at things like admissions to hospital, and it's just the numbers would be way too small, particularly with the pandemic. I don't know that you'd get an accurate response on that either. So I think this will be really useful. So that's as far as I know from the latest update I've seen via email, but hopefully I'll be able to attend the meetings going forward because they've changed time now.
Thank you, Emma. Jill, do you want to come back?
Thank you for that. I would hope that someone somewhere in one of the departments would consider data from the schools, children's behaviour. I mean, it must be far-reaching within the families. I think about my own maternal instinct. If I was in one of those houses, would I stay with my children? No, I most certainly wouldn't. Maybe that sounds hysterical, but I do have a very strong maternal instinct, and I just wonder how it is going to impact families in the future, and in fact what it's doing to them now. Thank you, Chairman.
Thank you. Really useful. Emma, is there any way that you could take that set of comments away? I'm mindful that in the report I think I saw a figure which suggested at least 29% of people were looking at moving to get away from the stink. Is there anything that you can do just to look at the existing work that you've got going on and the work that's going on with Keele and the work you've done and taking forward some of the comments in terms of school data and pulling that together?
Yeah, I can certainly ask, and I'm not an expert in schools data, so if there is anything out there that they're collating that would you know, help us with our research, I'm always happy to include it. Like I say, some of the other work, I've been looking at various different data strands, pulling them together to try and get a picture of what's going on. So the more, the better, really. If there's a source that we can access and do something with in a way that we can make comparisons, that's fine by me. And I'll certainly pass the comments about sort of impact on families and stuff like that.
That'd be really useful. I think committee would be pleased to receive that by written response as and when you've moved that further forward. Claire, do you want to come in?
Thank you, Chair. I'm afraid I don't have detail, but what I can just say is that underneath the strategic coordination group, there is a group looking at community impact, which is led by Newcastle Borough Council, and they have been in contact with schools and estate agents and some others like that. So we'll make that link and make sure that you get an update from them.
Brilliant, thank you. And we'd be happy also, Emma, to receive your report once you've had it all signed off and released as well.
Yeah, no, that's something that I was hoping to get sorted soon. It's out of my hands. It's kind of gone to other people to check and make sure everything's okay now. So as soon as I can, I'm hoping that can be shared. We need to meet about that soon to discuss how we do that going forward. It's quite long, so maybe we might need to sort of make it more accessible.
I'm sure there'll be an executive summary that even I might understand. Jill, do you want to come back on anything? Let me bring in Richard Cox.
Thank you, Chairman. A lot of the information we've got here is on the 3 miles, within 3 miles. I did ask when we were in Newcastle regarding the health implications of a radius of 4 miles plus. I don't see that there's any data being collected on that. Could you be able to confirm otherwise?
No, the surveys do collect the data for everybody. It's just the majority of the responses have been from an area of 3 miles or less. There are still ones outside that area. It's just they probably form a lower proportion of all responses. So they will be skewed by those living nearer, which is kind of what you'd expect given the location of where it is and that. Okay, so they are in there.
No, appreciate that for that clarification. That's very helpful. Just to clear my mind, obviously 28 caps. Obviously you're capping the gas. Is there dangers of build-up of gas that may cause further problems down the line in terms of health? I'm not too sure. I don't really understand it, so if any help towards that would be helpful.
Yeah,
Mark,
sure.
I guess that's one of yours.
Yeah, sure. Thank you, Chair. So just to be, so it's 28 wells that are being drilled. So in total, that will bring it up to 83 wells. So the wells are what are kind of horizontal pipes that are drilled within to the landfill to actually extract the gas out. So the capping is about containing the gas so that it doesn't come through the ground. So that's what we call the part of the kind of contained strategy side. So the capping is about putting a layer of material across the top of the landfill so that fugitive emissions don't come through the ground, and then wells are drilled within certain parts of the landfill to extract the gas out. So that means that gas isn't obviously then building up underneath that would then cause, you know, what you possibly would imagine could do if nothing's extracted out, which is a large plume that would all of a sudden come out. So the whole point of obviously capping and drilling the wells is all around the contain and capture, and all that pipe infrastructure work extracts the gas to the gas utilisation plant, which I described earlier, and that's where the gas is destroyed, and that's either through two ways. It's either converted into energy, which goes back to the grid, electrical energy through engines, or it is burnt by the flares. So the flares will then burn those gases off, which obviously go into the atmosphere. But those that do go into the atmosphere is all the harmful gases obviously destroyed before it is released. So there is all that mechanism in place. So just in terms of the question about the concern around it all building up, that would not be the case, because that is where the wells are put in place to extract the gas to ensure gases are not built up.
Thank you, Chairman. That's very good. Thank you.
Thank you. Let me just summarise and bring a couple of points to conclude this session. So first of all, thank you to all our contributors, Emma, Claire, Mark, Alec and Ovnia. I think that's been a really useful summary in terms of following up our meeting in July. I thought the two reports were clear, so thank you for that. Maybe next time we bring a report, an update report, so we can also have a mental health element to it, because that would feel to me to be the bit which is probably missing from the reports themselves. Not a criticism, just an observation, particularly given what Emma said in the early part of the discussion about the long-term impact on mental health given the progression of time. Second point I wanted to make was I really appreciate and welcome that the data on the volatile organic compounds, VOCs, all of those other things outside of hydrogen sulfide, that data has been shared and it doesn't raise any concerns. That's really helpful. I was very concerned that there wasn't a free flow of information between all partners on the Strategic Management Board, so it's nice to see that, so thank you. And equally thank you for setting aside any concerns that we might have had on that. That's helpful. The next thing I wanted to just raise was the symptom tracker, which is, I think, the real thing that is continuing as an ongoing basis. Next time we see this, it'd be good to see the symptom tracker by month, i.e. are the number of people raising issues declining, much like the level of hydrogen sulfide seems to be declining, because that's a good barometer for us to look at. Maybe we can discuss that next time. And finally, just a question for today is, we talk about, and we can see that the level of hydrogen sulfide is going down in all monitoring stations. F9, the one by the Severn Trent one anyway, continues to be above the US EPA reference concentration level. Where do we think we're going to get to, and when? And I know that's a forecast, and people don't like necessarily making forecasts because you become a hostage to fortune, but this has been going on a long time, and I'm sure residents would like to feel they understood where the situation might get to. So if anyone wants to pick up any of the comments, particularly the last one, that'd be useful, but otherwise, thank you for contributions so far. Mark, you may want to pick up where's the forecast for hydrogen sulfide? Oh, sorry, Claire.
I can come in on that, Chair. I mean, this is not to make light of what you're saying in any way, shape or form, but this is the million-dollar question. There are a number of things in that landfill, and have been all the way through in terms of its response, which are not, and certainly in the early days, were not responding in the way that we ordinarily would have expected a landfill to, or that we've seen across the rest of the country. And we have brought that expertise in from across the rest of the country, inside and outside the Environment Agency, and working with international colleagues as well. What we are seeing now is that those levels are not only dropping, but that there has been a consistent reduction, albeit with some variance within it, over a number of months. And that gives us confidence that the measures that we're requiring Wally's Quarry Limited to put in place are having the impact that we would expect them to. But going into this stage of the year, when we know that the hydrogen sulfide is likely to stay in the area for longer because of the colder weather, it would be wrong of us to set a date when we are saying that it will be over and those numbers will be down where they need to be, because we can't give you the absolute confidence with that. What we can do, and what we have done in the plan, is being clear that all the way through we have been requiring the operator to do everything that is both legally available to us and is sensible to be done. There are other issues that we need to be mindful of, or we are being mindful of, around risk of landfill fire, around sulfur dioxide emissions, all kinds of things there. So that's all part of what we're doing. We are working towards those dates as soon as we possibly can, and we are seeing that at 3 of the monitors, those levels are already being achieved. So I can't give you anything other than everything is moving as we would want it to at this stage, albeit we recognise that the community's been living with it for a long time.
Thank you. Claire, Alec.
Yes, thanks, Joe, and thanks, Claire. And just to add to what Claire has said, we've now just got the data in for September. We can say that, although obviously the report for ourselves isn't out yet, it won't be out for a few weeks, that concentrations continue to decrease, certainly at NLF9. So we're again seeing month on month another decrease in those concentrations. So when that gets reported out, that's again a good news story, that concentrations are continuing to fall.
Thank you. Appreciate both those responses. That probably leaves me with a question in terms of when we invite you back. It's been 3 months since we saw you last, so maybe with committee's approval, we invite you back in 3 months' time, and ask also just to see a continuation of not only this data, but also picking up anything that's been published and reported on mental health. Obviously, no need to wait until committee if you've got reports that are being signed off and finalised. You know, I'm particularly thinking about Emma's specifically, but is that the view of committee? I think we're unanimous on that, so just wait. Emma, do you want to just come in before I close this bit?
Yeah, you mentioned about the symptom tracker and responses reducing. I can confirm that is happening. Some days we don't get any responses at all from it now. Again, I'll try and pull something together just to put that into sort of like a trend chart so you can see it.
That's really helpful. I think all of the reports are helpful. I think today's contribution has been helpful. It's been a long period of time that residents near Wallis Quarry and Silverdale have been subjected to hydrogen sulfide, but it certainly seems that progress is being made, and that's good to see. Now it's about what is the long-term health impacts of that. So can I just thank all of you, Emma, Claire, Mark, Alec and Ovnia, for your involvement this morning. That's been really helpful, and thank you for the clarity of the reports. It's always good just to see some actual data. So thank you, and with committee's permission, we'll move on to the next item.
Thank you.
Okay, so item number 8 on the agenda this morning is the COVID update, and Emily, it looks like you're leading on this one. Can I just make an obvious point, which is we're many, many months into the COVID pandemic. This has come before committee several times, millions of times, not millions, a number of times before. So please don't take us back through all the history. Let's just take an overview and an update, please.
That's not a problem. Thank you, Chair. I shall share my screen and the pack shall be shared with the group following the meeting. I shall very quickly cover the most recent update and then open to questions. You should be able to see my screen.
Yes, we can.
Thank you. So COVID case rates remain high. They are above the England and West Midlands averages. The excess is accounted for by school-aged children, with many shires having a similar phenomenon as us. While school-aged children have the highest case rates, they are increasing across all of the age groups. Hospitalisations are starting to creep up nationally and locally. NHS and social care continue to experience substantial pressures due to a combination of rising demand and workforce shortages. But however, deaths from all causes remain around the same as the 5-year average. Vaccinations, so the booster and the 12 to 15 years programmes has slowed due to issues with general practice and MPFT capacity. Also, the younger age group has the highest infection rate at the moment, and there is a 28-day delay between infection and when you're able to access your vaccinations. That is causing an onward delay as well. But police are taking anti-vaccination campaigners quite seriously, and the 12 to 15 years can now book their vaccination online. So we're hoping that that will invigorate that further. Chair, that's the update.
Thank you, Emily. That was, I love it when people actually do what they're asked to do, but that was very, very brief. Let me take Jill Hood.
Thank you, Emily. I want to just tell you a little story very, very quickly. 6-year-old grandson sent home from school, PCR tests booked that afternoon, went and had it done, were advised, as usual, down the throat, up the nose, completely wrong. We sailed through, handed in the test. 3 days later, we haven't got anything back. So the next day, I book an appointment for another PCR test. We go through the same rigmarole, but this time it's a different story. No, you don't have to put it down the throat, just up the nose. Right, great. He'll end up having no front teeth because I'm having to bribe him with sweets, but there we go. So I get to the checkout where the guy hands me his very attractive washing up bowl to put in the file, and I say to him, I have 2 cards. No, you can't have. I said, I can assure you I've been given 2 cards. Oh, right. Which one ends in 35? None of them. I hear him turn away. As he turns away from the car, I hear him say as clear as anything, that means they're all wrong. We still haven't had the results back. That was 5 days ago. So this afternoon, we're tootling off to the same place. I'm just wondering, without being too caustic, are your really helpful volunteers who now have probably gone away back to uni, back to work, are you now having volunteers who are not capable of running these testing centres? Because I've spoken to a few parents, same school, and it's the same story, and I'm very worried about it. Thank you, Emily.
Thank you. I'm sorry to hear of your experience, and obviously without specific details of the test sites and dates, I can't address the individual issue. But what I would suggest is the test centres, the testing rates in Staffordshire are one of the highest nationally. We have a really high test rate with a high turnaround rate, and a high test result. And that test result is indication of the test going smoothly. In the example that you're providing, it would indicate that the results are lost somewhere because of an administrative error. If there are individual circumstances, we'd welcome the feedback in so that we can root cause it and find out what may have caused that and the type of test centre. But I'm quite confident that the volunteers are dedicated. They do have the training that they need, and that these incidences should be very few and far between.
Thank you, Emily. Maybe an exchange between yourself
Please.
And Councillor Hood with more of the detail, so it could just be investigated, because obviously if there is someone who isn't fully trained, then Jill.
Yeah, Emily, I have no doubt that the volunteers are doing an excellent job, and all the way through, I can only speak about Stafford. I've taken many people to the PCR testing centres, and they are incredible. And I think it's Homecroft where we've actually nicknamed the volunteers there the Happy Clappers, which is just wonderful. They are incredible, but there is obviously some kind of a breakdown to the test centre where I have been taking said child. Thank you, Emily.
Thank you.
Philip.
Yeah, I wouldn't take anybody for a PCR test. I've had similar problems, and it's the disruption to people's lives that, because they haven't had a result back, or it's wrong or negative, or they've not got the numbers mixed up. Just a bit of anecdotal stuff. I saw Amanda Milling on Friday night. She's a minister now in the Foreign Office, and the different attitudes in different countries. We're very lucky in this country. In Japan, she was escorted from the airport to the residency where she had to stay, and then escorted back to the airport. Singapore, you have to wear masks at all times. In Singapore, you wear masks at all times. If you go out for a meal, you can only have a meal with one other person and have a meal on, and have a mask on. Sounds fun, doesn't it? We're moving from pandemic to endemic, and sooner or later, I'm just wondering when we're going to start testing for flu or colds or whatever, and people are getting very unnerved by this constant drip, 43,000 cases, deaths are coming down. They've even stopped. I was quite disgusted with the BBC. They were saying deaths from COVID, not deaths with people who've had COVID in the last 28 days. There is some really bad messaging going on here. It's disrupting a whole host of people. And there are sensible things that you can do, such as the Year 9, I hate these Year 9, the 14-year-olds at Thomas Lanes were all sent home because of a potential spike in COVID in that year group. Quite sensible. They're able to look after themselves. They can isolate themselves at home, and everything's in in place to teach them at home. So, you know, I think we're beating ourselves up, but thank you very much for the very short presentation, because we're up to a neck in facts and figures about it.
Emma, do you want to come back?
Thank you for the information. I would agree, and I think as a board, as we're going the data that's available, it's I think a difficult position is that the raw case rate is high, but it's whether that should be a concern or not, which is why we are so furiously, you know, monitoring what's happening in our hospitals as opposed to that being sort of blinded by the number. So I think I would agree.
And obviously, your shorthand for hospitals is hospitals, ICU, and death.
Yes, absolutely.
Because I think they're all relevant. There are, you know, it used to be a very clear a movement through that. The movement is still through that, but in significantly less numbers.
Mm-hmm.
Philip, anything you want to come back on? No, I'll move on to Janice then.
Yeah, thank you, Chair. Just a very quick question. Probably very aware of the report in the media about the local neighbouring test centre over at the Science Park in Wolverhampton that was giving out false results. Yes. Just an opportunity to maybe give some reassurance as to where some of the tests go in Staffordshire possibly, and the accuracy of those. Thank you.
Thank you. Yes, it's something that we investigated. Also, I can confirm that no Staffordshire tests were sent to the test centre in question. Our tests are sent to a couple of different locations, one of which being sometimes Kiel, sometimes further north, but none of Staffordshire tests have been sent to the laboratory in question. The only time that we move outside of that is if we're doing emergency testing or some sort of outside testing, and usually we arrange for the samples to be processed at Keele University when we do that.
Thank you very much.
All very simple. Thank you, Emily. Thank you, Janice. Just let me ask a question, if I may, please, in relation to the third dose, the booster dose. So first point is maybe we could include what the level of the booster dose is across the relevant population, because it's obviously not all the population, on the next slides, or next deck of slides we see. And anecdotally, I'm getting a view that it's not rolling out as fast as, you know, maybe some of the narrative would suggest that it should be or it could be. Could you put our minds at rest that this is rolling at full pace, and that equally the flu vaccination is also rolling out as well, given the comments from within the health system earlier in the morning about winter pressures already being felt now?
Yes, I don't have any specific data, so apologies that was not included in the pack, and I shall feed back and get that included for future meetings, Chair. Thank you for the suggestion. The reassurance I can provide to you is that, yes, in Staffordshire, our vaccine and booster programme is working at full pace, and we are in a good position. To give you some anecdotal information, I can share with you, for example, where health have been struggling with delivering vaccines for a number of reasons. We've offered to help with things like administrative support, telephony activity, booking people in, and using some of our in-house systems to aid and help our partners so that we can support that rollout. I will arrange for some figures to be shared to give you the reassurance and the specific detail. I'm sorry I don't have that now.
No, that's fine. I think we'd gratefully appreciate that. And just maybe a figure in terms of whether we're on track with flu vaccination as well, accepting it's GPs who will be doing, or probably both of them in fairness.
Yeah.
I'm not seeing any further indications. So Emily, thank you for your input this morning. Thank you as ever for the clarity that you provide. We would love to receive the additional information on the third jab and on the winter flu. Otherwise, we'll thank you for your involvement this morning.
Thank you.
So let's move on to item number 9 of the committee agenda, which is district and borough updates. Clearly there are an overview of what's happened since our last meeting. Should we take the verbal updates? Martin.
Thank you, Chair. We had our last meeting on 14th September at Cannock Chase. We've split it up into 2 focuses that we want to work on. One is envirocrime, and the other one is waste and recycling. So we've set up 2 working groups. The envirocrime has met, and looking at what questions we're looking to pose to the officers and how we can scrutinise the processes of how we deal with envirocrime. So that's going on. The next one will be waste and recycling on the 9th of November, and those will report back to the next committee meeting on the 30th of November. Just a quick one from the MIU issue with our portfolio leader for community engagement, health and wellbeing, Councillor Val Jones, wrote to the CCG. There has been no answers back as yet when I spoke to her last night. She will be writing to them again today. So hopefully we'll have something to report back to our scrutiny meeting on the 30th.
Thank you, Martin. Just in terms of the Cannock MIU, I know that I've had an exchange with maybe the chair of your committee, but you were the chair of the committee, aren't you? So I have had an exchange, certainly with your council leader at least, on that. So maybe we'll take that outside of this discussion if you've not already had it. Apologies. Okay, Colin.
Thank you, Chair. Just to update members, at our last committee meeting, which Councillor Atkins, yes, was grilled, I have to say, we've decided to put together a couple of working groups. One is to, the old chestnut now is GP access, and the other is to see the effects of COVID that it's having in East Staffordshire. You know, I know we're covering a lot of this, but we have to cover it for ourselves in East Staffordshire, so that's what we're doing. And really, 2 reports that we are doing at the moment, which is a waste review. It should hopefully be in place by our next meeting here. If not, it will be the one after that. The other, which was engaging communities, is almost there as well. So we're working through that. Thank you, Chair.
Okay, thank you. David.
Thank you, Chair. We follow Cannock virtually in that the closest I can get you to health overview and scrutiny is the dual recycling programme and the climate control or climate emergency. We've got task groups being set up to look into those. As you know, we have a problem with doctors' access, and I did arrange to meet with a GP who's a senior member of the CCG, but he didn't keep the appointment. So I will let the county deal with GP access, if that's okay. But we are now setting up a fairly lengthy work programme for this new single ONS committee. And with that, I will have to leave early. I do apologise.
Thank you, David. Just let me make one comment, which is, in terms of GP access, it is clear that the principle of GP access rests with this committee. If you have a specific concern about an individual practice, then, that should be picked up locally, because there are 2 different aspects to that issue. It's a general performance issue with a practice, then that needs to be picked up locally. If it is about the general issue of GP access, which is a national issue after all, then that should come into this committee's remit so that we are not duplicating work. And if there is any confusion or lack of clarity, by all means take it through your scrutiny officers and Deb Breeden, who will be more than happy just to make sure that dividing line is clearly undertaken. Good. My only other comment was going to be in terms of Tamworth, which you know, really interesting to see the comments and summary from the Tamworth meeting, because all I'd say is it sounds like it was a great meeting, and I'm sorry I wasn't there. Okay, let's move on to item number 10 and on to the work programme. Two comments in terms of the work programme. One is what the committee want to do following last Thursday. And the second one was there is an opportunity in terms of the wider determinants of health for all district and borough colleagues to input ideas of best practice in terms of what you know is going on in your patches. And I'm sure Councillor Edgeler would be more than grateful to have. I'm sure she will be. She might not know it yet, but she will be. More than happy to have examples and to have your active involvement in those discussions. Philip.
Thanks, Chairman. I think there's certainly something going on in my real life about food and global implications and obviously the effect on obesity. It really is strange that we're in a position that food prices are going up because of shortages of commodities, and yet obesity seems to be an issue. So there's something about, you know, it's a wider issue. It's probably more than this committee could possibly look at, but people don't cook their own food. You know, I always look at what's on the packet when anything comes in. You'll be amazed how many chemicals there are that I use to control crops. And the other one is that I noticed we've got West Midlands Ambulance Service on Monday the 13th of December. I was rather alarmed to read in East Staffordshire, I didn't attend the meeting, they seem to be going back in time. You will have heard about the issues about the what was called the Elks Biscuit Factory in Uttoxeter, and the two sisters have said the site's up for sale. But I never knew that somehow they'd ended up with an ambulance post there. I suspect all it was somewhere where ambulance crews could go and have a wash and use the toilet, I presume. Anyway, that set the town council off about they'd lost their ambulance post and they wouldn't have an ambulance in Uttoxeter. And there were some very long delays reported at the town council meeting in the public forum, and representatives went there. They blamed the hospitals. There's plenty of ambulances, there's plenty of crews, but they can't get people out of the ambulances into the hospitals because the hospitals aren't getting them out at the other end. I thought, I heard this with Roger Thane 15 to 20 years ago, and he wouldn't put it out in public because he was afraid of what might happen with the NHS and his job. To think that we've gone from Staffordshire Ambulance Service, which was the best in the country, to one that's not meeting just pretty basic response times because of hospital delayed discharges is what they're saying. I don't think that's actually the case, because if they're reporting that now, by the time we get round to December and having a look at it, it'll be a nightmare. So I'm just a plea whether whether they turn up or not, I don't know. But it said requested 20th of September meeting. You know, they did turn up at Uttoxeter Town Council.
Thank you, Philip. Before we move on to Richard, let me just pick up a couple of those points, if I can, starting in reverse. The whole purpose of getting members of the ambulance service, the CCG commissioning secondary care and social care all together at the meeting on the 13th of December is to have exactly that discussion. So I don't suggest that we do a pre-run of that discussion. As much as I would like to, and as much as I'd be tempted to take the bait, but I'm not going to. But I think the point is well made, and that's the whole purpose of this committee scrutinising it, and I think it does at least demonstrate, yes, everyone can point at each other, but at the same point, they're all in the same room at the same stage, so I'm hoping we'll have a meaningful debate on that.
Chairman, that's the beauty of an in-person meeting. You saw me do that.
I think we've already had that discussion, and I think my view was fairly clear, because I wish I hadn't kicked off that discussion earlier, but I did. Just moving on, so I'm not trying to avoid that one, Philip. It's definitely there. It's really important for all our residents. Second one is in terms of food and obesity. I absolutely agree, and it should be part of the discussion that Anne is pulling together, and I'm sure she'll be in contact with you, Philip. I would also say let's not lose the flip side of that. I know too many young people who are too concerned by food and what they eat, and sometimes we can frighten people into the wrong behaviour as well. So it's a really delicate balancing out on both sides of that, and I'm sure that we'll pick that up. So let me move on to Richard Cox.
Chairman, I don't want to particularly labour the point about what Councillor Atkins has just said, but just as an example, there was an incident in my own village at the pub car park where a guy, quite a large guy, didn't just twist his ankle, it was a 180-degree turn, it was in a mess, and we were told by the West Midlands Ambulance Service 5 hours. The good news was that we had a guy in the pub who is a first aid trainer, and he was superb. But it just put the point that we had to do it all there, not having the right equipment, although the pub first aid kit, but he did an excellent job, and they took him by car to Burton and then Derby. He is still in hospital. It was serious, and yet as much as we were trying to explain, it wasn't getting through that it was a serious accident.
Sometimes that pragmatic response is the right one, but equally, I'm not going to engage on a meeting we're going to have in 6 weeks' time, because I'm sure most members will be happy to have some lunch. Did anyone want to pick up the discussion on mental health and the outcome from last Thursday's session? And I'm assuming that members will be happy to send out those details to districts and boroughs that they sit on. But is there any further work in terms of the work programme? And Angela?
Yeah, I just thought that it was a good meeting. There was so much in there that I had to sit down and read it all again, to be honest with you. So much to absorb, so I would suggest to members that, go through it all again. And picking up Philip's point about obesity, I've been on about obesity now, it must be 5 years, even at the district level, and the other thing is, we get Anthony Marsh here from the ambulance service, because I think he should be here to answer the question.
Thank you, Anne. I won't pick up the obesity point because you picked that up with Philip. Thank you. We have Mark Doherty and please, Debs, just remind me. So that puts you on the spot. We've certainly got senior members of the SLT from the West Midlands Ambulance Service who are coming to that meeting. They will be there on behalf of the senior leadership team. It's not for us to say who has to come in front of us. That is beyond our remit. But rest assured, there will be senior leaders from Murray McGregor. That was the name I had forgotten. Sorry, Murray. Janice.
Yeah, thank you, Chair. Going on from the mental health side of things, no doubt the rest of colleagues here have seen some of the emails that have gone round with the data showing the increase in demand on a lot of the mental health side of things. And that's also prompted a flurry of inquiries to do with the George Bryant Centre. So I was just having a quick look on the work programme from what we'd already looked at as to when that was likely to be revisited.
Specifically the George Bryant?
On a specific, yeah, but equally the wider capacity, obviously, with the demands generally on mental health, but certainly from our last meeting, when we did have those discussions, when it was going to be revisited as part of the work programme.
So the answer to that question is the George Bryant will come back when the consultation's finished and when the business case, and the initial business case has been pulled together, and then we will comment on the initial business case. I would hope it would take into account the wider Staffordshire context, which I think is the point you're making, and trying to anticipate future demand as part of that, because otherwise we're not future-proofing that. That's when I would expect that to come in.
Was there any time frame put on that? Because I can't see it on the work programme, and I certainly can't remember from the meeting, just as to when that is likely to be.
Whilst I'm just looking for that piece of detail, Anne's going to come in.
Yeah, thank you for that, Janice. I've got to say to you, and I wanted to say it before actually, with my governor's hat on at the MPTF, I've sat in a lot of meetings now to do with the George Bryant Centre under that auspice of the Midland Partnership Foundation Trust. And he only sat in a meeting last week, and it was quite interesting actually. The consultation, and they were consulting with the general public in that meeting, and it was very, very interesting listening to what the general public was saying about the George Bryant Centre. The main thing really was about transport. You know, how would they get to, if they got to come to Stafford or a bit like County and UHNM. But I just wanted to put your mind at rest that people were being consulted.
The options appraisal is coming back somewhere in January, February, March time next year, and it will do as we've just discussed, because it's important that it is A, future-proofed, and B, takes into account the wider context, and that's the purpose of the work that's going on. So there's an input in terms of consultation of individuals, there'll be a medical input, and there will then be a system redesign. I would expect Jane Moore probably with Marcus to lead on that.
No, that's great, thank you.
Thank you. Okay, I'm not seeing any further indications. So as usual, fairly lengthy meeting, particularly lengthy agenda, so thank you for members' input. And at that stage, let's close the meeting. The date of the next meeting is the 29th of November. Thank you everyone, safe journeys, enjoy the rest of your day. Bye-bye.